Department, RIMS Imphal, and
myself, Sandra Fernandez, postgraduate trainee, Department of Community Medicine, RIMS Imphal,
extend our warm welcome to one and all present here to the second day of 4th International Conference of Pallicon 2023. Yesterday was a very eventful day, giving us insight on the role of both curative and preventive medicine in palliative care, both nationally as well as globally. Let's dive into today's sessions covering the whole spectrum from pediatric to geriatric palliative care. For session 1, the theme is palliative care in children and emergency. For this session, I would like to request Dr. Sonamani, Consultant Hemato-Oncologist, American Oncology Institute, Dr. Gautam C.H., Consultant Neurosurgeon, Shija Hospital, and Dr. Anil Methi, Consultant Oncosurgeon, Shija Hospital and Research Institute, to kindly come up on the stage and chair the session. Sir, we would request you to take over the session. Thank you.
Good morning, everybody. The first session today is from Dr. Vashi. She will be presenting on taking care of children with life-limiting illness. She is an MD palliative care from AIMS New Delhi. Okay, here she may start. I call upon Dr. Neneva O'Keefe or Basi to present her session.
A very good morning to one and all present here. At the outset, I would first like to thank Dr. Nandan and his team for providing me the wonderful opportunity to speak on this platform. So, my topic for today is pediatric palliative care. I will be speaking on this topic. This is my outline. Briefly, I'll be mentioning the 17 United Nations Sustainable Developmental Goals, the definition, what are the differences between adult and child palliative care, the categories of life-limiting illnesses, the causes and the management of common symptoms that we encounter in our daily practice, the general care of the child, end-of-life care briefly, bereavement care, what are the various barriers, and summary. So, the 2030 Agenda for Sustainable Development by the United Nations has at its heart 17 Sustainable Developmental Goals. It was adopted in 2015 by all its member states. So here we have goal number 3, which is good health and well-being. So within this goal, we have a number of specific objectives. Objective number 3.8 is to achieve universal health coverage. Universal health coverage means that all individuals and communities receive the health services that they need without suffering financial hardship, which includes essential quality health services from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course of any individual. So the WHO defines palliative care for children as the active total care of the child's body, mind, and spirit, and involves giving support to the family. So it begins when illness right at the time of diagnosis, and it continues regardless of whether or not a child receives treatment directed at the disease. Healthcare providers must evaluate and alleviate a child's physical, psychological, and social distress. So, uh, like adult palliative care, providing adequate palliative care cannot be done by a one-man army. It requires a broad multidisciplinary approach and includes the family, the caregivers. It includes professionals from different specialties, from the different oncology, from pediatrics, from occupational therapists, from physiotherapists. We have the nurses, the chaplains, social workers as well, and it makes use of available community resources. It can be provided in tertiary care centers, in community health centers, and even in the children's homes. Stephen R. Connor and his associates in 2017 published an article on the Journal of Pain and Symptom Management entitled Estimating the Global Need for Palliative Care for Children, and it was estimated to be 21.6 million, with 8.2 million children needing access to specialist palliative care service provision. And they found that in India, there it was estimated that there are 1.6 million children in need of specialized pediatric palliative care. So, what are the various differences between adult and child palliative care? In children, the causes of death are different from those in adults. Thus, the palliative care guidelines which have been developed for adults are inappropriate for children. A variety of childhood cancer conditions are rare, and the length of illness can vary greatly from days to years. The child may survive into early adulthood, extending the palliative care over many years. Children continue to develop physically, emotionally, and cognitively, which means their medical, social, as well as understanding understanding of disease and death is very complex. Also, palliative care affects the whole family, and the burden of care falls upon the parents, the siblings, or the grandparents, and appropriate services are more likely to be home based rather than hospital based. Children's palliative care services are not organized in the same way as palliative care services for adults that is given. Also, children receive more aggressive care as compared to adults at the end of life and may require specific symptom and pain management throughout the course of treatment. So, in children, there are basically four categories of life-threatening and life-limiting conditions, which may or may not be mutually exclusive. So, a particular disease, a particular condition can fall into two or more of these categories depending upon the stage of the disease. Firstly, we have life-threatening conditions for which curative treatment may be feasible, in which there is an option of cure, but it can fail as well. Here, access to palliative care services may be necessary when the treatment fails. Children in long-term remission, however, children in long-term remission or following successful curative treatments are not included. Here we have conditions like cancer, like organ failure. Secondly, uh, the second category comprises of conditions where premature death is inevitable, where there may be long periods of intensive treatment aimed at prolonging the life and allowing participation in normal activities, in the activities of daily living. Example, so we have cystic fibrosis, muscular dystrophies like Duchenne muscular dystrophy. The third category are progressive conditions without curative treatment options, which means that the option of cure is only palliative right at the start of diagnosis. Here we have mucopolysaccharidosis, muscular dystrophies, Batten's disease, etc. Lastly, we have the irreversible but non-progressive conditions causing severe disability, leading to susceptibility to health complications and the likelihood of premature death. Here we have cerebral palsy, post-accidents, multiple disabilities such as following brain or spinal cord injury, etc. This is a graphical presentation of what I just discussed, where group 1, we have the conditions, life-threatening conditions where treatment, the curative option is available, but it may fail. Group 2, as we can see, we have Duchenne muscular dystrophy. Group 3, we have Patton's disease, where the only treatment is palliative right at the start of diagnosis. And Group 4, there is an original insult following which there is deterioration in the health of the child. Coming to the symptom management. So the principles of symptom management include, firstly, that we must correct the correctable causes. We must use cancer modifying treatment. There must be care of the mouth, back, eyes, skin. We must treat infections properly. We must correct anemia, lymphedema care, etc. Then we have symptomatic drug treatment, and lastly, the non-drug treatment options. So let us discuss a few of the common symptoms. Firstly, we have pain. Many of us will be familiar with how to deal with pain, I'm aware. So we follow the WHO principles of pain management, which is similar as that of adults. So we have the pain management should be by the WHO pain ladder. It should be by the clock rather than on an SOS or PRN basis. It must be by the mouth, if feasible, and it must be by the individual. So the adequate pain management involves pain assessment. So we have different pain rating scales for the pediatric population as well. The behavioral and physiological measures include the FLAG scale, which stands for face, legs, arms, cry, and consolability. Then we have the CRY scale, the PIPP scale, which stands for premature infant pain profile. Excuse me. Then we have the NIP scale, the neonatal infant pain scale, and the comfort scale. Also, there are self-report and assessment scales such as the visual analog scale and the Wong-Baker Faces scale. This is the scale, the Wong-Baker Faces pain rating scale, which can be easily used for children. It has a rating, one end of the spectrum, where 0 denotes no hurt, there is no pain at all, to the extreme end of the spectrum, where 10, which means hurts the most. Then FLAG scale is used for infants and up to 7 years of age for children. The face, legs, activity, cry, and consolability. We have the total ranges from 0 to 10, and the pain is divided into mild, moderate, and severe. Then in neonates, we also have the NPAS, or the neonatal pain, agitation, and sedation scale, which may be used accordingly. So this is the modified WHO ladder for adults, where step 1, for mild pain, we can use non-opioid analgesics. We have paracetamol, NSAIDs, adjuvants such as anticonvulsants, antidepressants for neuropathic pain. Then step 2 comprises of weak opioids, which includes tramadol, codeine, along with those of step 1. Step 3, we use strong opioids. Strong opioids, we have morphine, fentanyl, then methadone. Step 4, we have nerve blocks, epidurals, patient-controlled analgesia pumps, neurolytic block therapy, spinal stimulators. It is to be noted that step 4, the interventions can be tried at any stage, at any step of the pain ladder. It can be tried at step 1, step 2, or step 3 as well. Now, the difference between the adult and the child and the children WHO analgesic ladder is that step 2, which comprises of the weak opioids, that is not present in that is not present for the pain management in children. Here we have only 2 steps, step 1 and step 2. Step 1, for mild and moderate pain, we use NSAIDs, paracetamol, basically the non-opioid analgesics. And in step 2, which is the moderate and for moderate and severe pain, we use strong opioid analgesics, as well as regional blockades can be given. So who should be treated using WHO guidelines? It must be used for patients with cancer-related pain and for other palliative care patients, such as those with end-stage liver diseases, heart disease, kidney disease, lung diseases. It should be used in pain for patients with HIV and AIDS, for cerebral palsy, for spasticity as well, for muscular dystrophies, and various neurological conditions. The opioids which we are commonly familiarized with include morphine, fentanyl, and methadone. These are the various doses which are given orally. Some are given fentanyl, which is available only in the IV, and the patches, transdermal patches. And we have methadone, which is available orally in India. Now, care should be taken to provide adequate pain management even while doing the procedures, such as bladder catheterization, chest tube removal, circumcision, lumbar puncture, etc. And these are the various means of pain reduction, some pharmacological, some non-pharmacological as well. The non-pharmacological strategies include supportive counseling for the whole family during the course of the disease, during any procedure, during the treatment. Then we have behavioral strategies such as breathing techniques, relaxation techniques. Then we have others such as the transcutaneous electrical nerve stimulation, touch therapies, then occupational therapies using braces, splints, and cognitive therapies using imagery and hypnosis. Physical comfort measures include positioning, rocking, cuddling, massage using heat and cold packs, acupressure, and physiotherapy. Coming to the next common symptom, nausea and vomiting, there are multiple potential causes, and a thorough assessment of the cause is crucial in order to manage it. For example, the most common causes, include, which we encounter in a daily practice, would be treatment related. It would be chemotherapy or radiotherapy related nausea, vomiting. It can be because of the space occupying lesions of brain causing raised ICTs, in cases of TB, in case of brain metastasis causing nausea, vomiting. It can be because of intestinal obstructions, hepatic dysfunctions, severe constipation also can cause nausea, vomiting. Renal metabolic causes pain, and once everything is ruled out, even psychological cause is also an important and in fact a difficult cause to manage. So the management, as I've mentioned earlier, would be to correct the correctable. If it's centrally induced, we use drugs like haloperidol. Drugs acting on the chemoreceptor trigger zone include those of dopamine blockers, which are also prokinetics. We have metoclopramide, domperidone. Then we have the ondansetron, granisetron, serotonin antagonists, and second line, which in cases such as intestinal obstruction, etc., in cases of brain metastasis, a trial of steroids can be given, and olanzapine, which is a wonder drug for nausea, vomiting. Then we have dyspnea. Dyspnea, again, there may be multiple causes. We must correct the correctable. If there's fluid, we must remove the fluid. We must correct anemia. We modify the behaviors, low-dose steroids and bronchodilators. Trial can be given. Oxygen is controversial in palliative care. However, it's useful only with desaturation. In non-hypoxemic patients, it may serve only as a placebo. And oxygen, the disadvantage is that it may be difficult to arrange at home. The patients become dependent on it, and they become difficult to discharge. Even though we find that they may be only on minimal oxygen support, just 2 to 3 liters, 2 to 4 liters also. So we must not make them dependent on oxygen in palliative care patients. So the non-pharmacological interventions include, example, just opening the windows, avoid crowded places, limit the number of people in the room, use relaxation techniques, diversion therapy, and support and educate the family and caregivers. In cases of terminal breathlessness, studies have shown, in fact, it is evidence-based that opioids have a role in terminal breathlessness in reducing by various mechanisms. In opioid-naive patients, we usually start morphine, can be started, oral morphine can be started at a dose of 0.1 mg per kg, 4 hourly on opioids or on if the patient is already on opioids for pain, 25 to 50% increase in the existing dose can be done and must be titrated daily. Benzodiazepines can be used for uncontrolled agitation, anxiety. Also, here again, oxygen is controversial. So So lastly, in case in severe refractory symptoms with breathlessness, with pain, nausea, vomiting, we can go ahead with palliative sedation. Then we have fatigue. Fatigue is one of the most distressing symptoms in advanced illness. Here we must correct anemia, fluid imbalance, depression, pain. Low-dose steroids, and majestrol acetate can be tried for improving the appetite. Then we must modify lifestyle, diet, and give the child ability to express. So the general measures in taking care of the child include, so we must encourage the child to be as normal as possible. We must, if feasible, if the child if the child has a relatively good performance status, we must encourage the child to go to school, to play with peers, to play games at home. We must give small but frequent, tasty, unconventional meals. Diversional therapies such as cognitive behavioral therapy, etc., can be tried. We must counsel the child and family and be the advocate for the child. And the other diversions such as picnics and outings can also be tried. So, end of life care. Whatever the disease is, a child may approach the end of life. Here we provide end of life care, and the basic aim of providing end of life care is to achieve good death. So, Dr. Puneet will be speaking more in detail regarding end of life care. This is this is the guidelines for end of life care, which was established in 2020 by Dr. Sushma Bhatnagar and her team at AIMS New Delhi. Here we have basically 4 steps. This applies to both adults and the pediatric age group. Here we have 4 steps. Step 1 is to first establish the futility of further management. Based on general criteria and disease-specific criteria. This must be verified by the primary physician and a second physician. Once that is done, then there must be consensus among all the caregivers on the futility of further management. Then we can start the best supportive care. So step 3 would be initiation of end-of-life care pathway, and 4 would be symptom management and ongoing supportive care till death. It must be noted that it is very important to document each and every step of this process. So, the pediatric palliative care, as with adults also, does not stop at the death of the child or any patient. Palliative care extends into the bereavement period as well. So, grief is a normal process, and most families do not need specialist help. Bereavement is an objective situation which one faces after having lost an important person via death. And a child's death can be a life-altering experience. Parents may experience extra guilt or they may blame each other, often resulting in subsequent marital difficulties. Therefore, it is our duty, therefore the professionals who have been working with the family should be prepared to continue their support in bereavement. So there may be different ways in which we can help the family, such as funeral preparation. We can ask them to go for family-focused grief therapies, which consist of weekly as well as bi-weekly sessions. So, coming to the barriers, of course, it is a challenge for providing palliative care in different parts. Some of the barriers when it comes to providing adequate pediatric palliative care include, so there is a taboo around child death, and without an open and honest approach in dealing with death, families are often forced to make inappropriate and ill-informed decisions, and they attempt in order to attempt aggressive curative treatments. And there is a huge lack of understanding about about what children's palliative care is. It is important to notify that families should not have to choose between disease-directed therapy and palliative care. My job is to induce awareness among the healthcare professionals, among everyone involved here, that choosing the treatment for the disease and palliative care can go hand in hand. It is not mutually exclusive. So that is one. There is lack of trained personnel worldwide, scaling up palliative care program, which makes scaling up of palliative programs difficult with limited resource capacity. And last but not the least, there is insufficient research and evidence based on the use of medication to treat pain and other symptoms for children. This is the summary of my lecture, where palliative care is started right at the time of diagnosis of any life-limiting condition, through the early stages, and into the deciding the goals of care, advanced care planning, into the service delivery, into the end of life, and even into the bereavement period. So I would like to bring to your attention Project ECO. ECO, which stands for Extension for Community Healthcare Outcomes, which is a teleteaching or a virtual-based learning program which had been developed in 2018 by Dr. Megan Doherty and colleagues. Here, it connects experts in pediatric palliative care with healthcare workers caring for children with life-limiting illnesses across South Asia, and provide practical training using web-based video conferencing. Here we have lectures, we have case discussions, we have all sorts of interactions. So anybody can participate. All levels of providers, including physicians, nurses, and allied healthcare providers, can enroll for this course. Another is the CAN support, or the NGO which my department has been affiliated with, which provides assistance to children with terminal diseases such as cancer. Here, over 72,000 children have been supported. It is available in more than 100, in approximately in more than 120 cities across India. I think it has reached some parts of Assam as well. So this is just to inform you regarding this. Thank you.
Thank you, Dr. Hockey. It was a nice presentation. Let us know where you work now to the audience so that we can also use your expertise in these cases.
Yes, sir. So I've recently completed my MD in palliative medicine. I completed my MBBS from Lady Harding Medical College. So right now I'm in the middle of, I'm applying, I'm looking to settle here in the Northeast. So I'm planning to come back home, sir.
Okay,
Yes.
you belong to Manipur, you used to work here. Yeah.
Thank you, sir.
Yeah. Being Mortal is a very good book by Atul Gawande. So all those who are dealing with palliative care, I think everybody should read this book. Okay, thank you. Any comments?
I think we will finish the session first, and we will invite comments and any queries, questions after the end of the. We have another lecture. We will have a discussion after that. Thank you, Dr. Neva.
Thank you.
We will come back to you. Thank you. Next, I would like to call upon Dr. Sandeep Lamba. Dr. Sandeep has completed his MD in emergency medicine from AIMS New Delhi. He is currently working in Manipur Health Services. He has participated in many workshops, completed faculty trainings, and other training programs related to emergency medicines. He will be speaking today in a very important topic where most of us clinicians fail to identify early. So we'll be talking on palliative emergencies. Dr. Sandeep, please.
Thank you for the kind introduction. Sandeep. And I'd like to start off by saying that I would like to thank Dr. Nandan for extending the invitation to speak on this topic. I was really excited initially because having worked extensively in my PG days with palliative physicians, I was aware of the spectrum of diseases that they also have to see. The spectrum, the length and breadth of diseases and conditions that they have to deal with. So it is not only the palliation aspect of palliative medicine that is important. It is also important to stress that palliative physicians and everybody involved also have a role to play when the patient deteriorates. So today my talk is on palliative emergencies. It is, as we all know, the length and breadth of palliative emergencies, like any other medical specialty, is varied and the spectrum varies. Like as Dr. Puneet yesterday talked about non-malignant palliative therapies, we not only have to deal with cancer patients. So I will be today talking about some important conditions that a palliative physician might encounter, and also would like to stress that early identification and early treatment not only may improve the quality of life, but also, in fact, save lives. So, I would like to start off by saying the main differences between what a palliative physician encounters as an emergency and what other most medical specialties encounter as emergencies. In other specialties, if the emergency is left untreated, then it might pose an immediate threat to life. The patient may die. But while on the other hand, in a palliative patient, if it is left untreated, there may be severe derangement to the quality of life. As an emergency physician, when an emergency comes to me, my main aim is to first save a life. But as a palliative care physician, the main aim is to relieve suffering. As an emergency physician, when I see a patient, most of the time, the emergency is unplanned, unexpected, like a trauma, heart attack, ACS. But as a palliative physician, the conditions that arises out of these patients are mostly expected. We expect the cancer patients to have certain emergencies, bleeding diastasis, pulmonary embolism, seizures. These are the main things that we generally do anticipate in these patients. As always, in palliative care, the patient is the centerpiece. We do have to consider the general condition of the patient, how the patient is coping with the situation, how much the disease has progressed, the stage of the disease, especially in cancers, if the malignancy has been metastatic for a long time, what are the treatment options available to us? If the family members can afford it, or if there are expected toxicities out of which the patient might have deterioration. So, what are the questions that we have in mind when I first see a palliative patient in an emergency? First, we have to recognize what is the problem. Is the patient having difficulty breathing? Is the patient having low BP? Is the patient conscious, unconscious, drowsy? For instance, can it be reversed? Can we do anything on the floor that will immediately help the patient? And most importantly, should we do it? That is the real question. Should we be going ahead and intervening? So, we do have to have a plan in place. We have to talk to the relatives, to the family members, that okay, your patient is at this stage of disease. We are anticipating these set of complications. We have to educate the patient and also the family members. And if we have a plan, we have to share it with the family members. We have to say, for instance, hey, if you are having low BP, if you are having drowsiness, if you are having difficulty breathing, you have to do these set of things. So what is palliative emergency? As I initially spoke about it, it encompasses a wide spectrum of conditions. It can be cardiovascular emergent, it could be neurological, it could be hematological, it could be infectious. In fact, infectious complications account for depending on which literature you look to, 30 to 40% of mortalities. So the conditions that we may come across varies. So also the uh, the things that we do for the patient. So I would like to start off by discussing 3 cases, because as we know, the length and breadth of the conditions that we may encounter is numerous. We have a patient here. He is a 68-year-old male who is a diabetic. He comes to our emergency department complaining of left-sided chest pain and shortness of breath for 4 hours. On primary survey, the airway is patent, but the patient is dyspneic with a respiratory rate which is elevated at 33 per minute. The SpO2 is 90% and the chase on auscultation is clear basically. The heart rate is elevated, the patient is tachycardic at 120 per minute. The BP is a bit low at 102 over 66 millimeter of mercury. The GCS is full, 15 by 15. The glucose seems to be normal. Patient is afebrile. Okay. The patient also complains of new onset hemoptysis. A smoker. What do we think? If I have to think, I will be thinking about pulmonary embolism. But when I look through his reports, through his patient history, I encountered that he has Hodgkin's lymphoma history and he is on chemotherapy. He was on chemotherapy, on remission. Now immediately, I have to ask myself, does my plan change for this patient? Do I intervene? So, I would like to talk about pulmonary embolism, and we'll get to answer this question later on. Basically, pulmonary embolism, very simply put, is when the thrombus enters the pulmonary artery circulation. The sources of emboli, as we all know, are mostly from the lower limb, followed by the upper limb and pelvis. Venous thromboembolism is a broad term that encompasses pulmonary embolism plus the DVT, that is deep vein thrombosis. Now, what is important to us as palliative physicians and also as an emergency physician is 2 types of pulmonary embolism, whether it is massive or submassive. There are other smaller embolism which does not pose real threat to the patient at a given time. So, massive pulmonary embolism is defined as acute pulmonary embolism with sustained hypotension. If the systolic blood pressure is less than 90 millimeter of mercury over a long period of time, that is 15 minutes. Or if the patient is requiring inotropic support, or if the patient is having arrhythmia, hypovolemia, sepsis, then we can rule it out. Or if a patient is having pulselessness or persistent profound bradycardia. Submassive pulmonary embolism is defined as acute pulmonary embolism without hypotension. If the BP is over 90 millimeter of mercury, then we may think of submassive pulmonary embolism. But with the caveat that there should be either RV dysfunction or myocardial necrosis. Very quickly going through what is RV dysfunction or what is, as I mentioned here, submassive pulmonary embolism. So if we all know that the left ventricle is larger than the right ventricle, if the left ventricle is approaching right ventricular size, as mentioned here, if it is 90% or more of the left ventricular size, then we also have to think about submassive pulmonary embolism. Also, there are other things like looking at the BNP, looking at the elevated NT-proBNP or ECG changes. But these findings or these labs may not be available readily to us. Like a BNP or an NT-proBNP is not readily available to everybody. So, as I mentioned earlier, a DVT occurs and then it gets embolized into the pulmonary circulation, thereby cutting off the circulation to the lungs. There are many risk factors. In palliative medicine, we not only see cancer patients, but we also see end-stage diseases, elderly patients, CKD patients, CLD patients. So they are already at risk. Obese patients, smokers, and this also, as Dr. Puneet mentioned yesterday, COPD patients. So these all conditions predispose the patient to a DVT and pulmonary embolism. Trauma patient, and most importantly, we have to mention cancer patients. What are the clinical features? One of the main reasons I chose to talk briefly about pulmonary embolism today is mainly because of the clinical presentation. I would like to take this opportunity to talk about certain red flags that not only applies to pulmonary embolism but to all patients of palliative care. Like tachycardia, if the patient is complaining of a very raised heart rate, the patient is breathing fast. If the patient is cyanose, his skin color is changing, his nail bed color is changing. Patient has low BP. Patient is elevated JBP. Of course, only a clinical physician will be able to differentiate it. But yes, as caregivers, the other 4 or 5 things can be appreciated. A pleural friction rub can be appreciated rarely. What are the symptoms? Dyspnea, very frequently encountered in palliative medicine. Cough, wheezing, hemoptysis, and syncope. When I was discussing just now the signs and symptoms, you will see that the signs and symptoms are very non-specific. Wheezing could be because of any other factor, an infection, asthma, COPD. The presentation varies. The low BP can be because of other things. The low BP can be because the patient may be bleeding out internally. There can be a host of things that could be wrong with the patient. So, diagnosis of pulmonary embolism is dicey, to say the least. But we have to remember that as physicians, the SpO2 may be low, the chest examination is mostly clear, and the chest x-rays are also mostly clear. We will be going through a few x-rays which shows interesting findings, but they are rare. So, hypoxemia or dyspnea, along with a clear lung examination and a clear x-ray, strongly suggests pulmonary embolism, especially in the setting of the presence of risk factors like cancer. So as you can see, this wedge-shaped area of lung parenchyma is what is known as Westermarck sign. What is this? This opacity that we see here peripherally is seen sometimes in pulmonary embolism, and it is known as Hampton's hump. Interesting findings, but not necessarily found in all patients. So, what are things that are easily available to us? A chest X-ray and an ECG. So, what are the ECG changes? We might see an RVBB, as we can see the complexes are wide here, and also an RVH with RV strength pattern. There are T inversions in V1, V2, V3, along with ST depression. As we can see, there is also minor changes here, but usually we have to look for RVH with RV strength pattern. S1QT2T is what's usually mentioned in the literature, but it has low specificity and sensitivity. As we see here, S waves in lead 1, okay, Q waves in lead 3, and inverted T waves in lead 3. So S1, Q2, T3. But please remember, although it is attractive to mention these names, but these are not pathognomic and not usually found. So basically, what we can do in the emergency department or on the floor or in the ward is try to rule out if it is pulmonary embolism or not. So if all of these factors can be seen or can be accounted for, then we can be pretty sure that the person is not suffering from pulmonary embolism. So There is no history of prior thromboembolism, O2 saturation of more than 94%, no tachycardia, age less than 50, no surgical history of trauma within the last 4 weeks, no leg swelling, no hemoptysis, no estrogen use. If any one of these findings are positive, then we cannot positively rule out pulmonary embolism. We have a scoring system. It's called a Wells score. It has been well studied and it has been used especially in the emergency department for a very long time. So these are the factors and these are the scoring. These are the points that is given. Point to remember is that if the scoring is less than 2, then the risk of pulmonary embolism is low. If it is 2 to 6, the probability is moderate, up to 26 to 30%. If it is more than that, then the chances increase up to 60 to 70%. So, ruling out the risk factors, doing the clinical examination, getting the x-rays, is it enough? What else can we do? We can go for a D-dimer assay. The D-dimer assay, if available to us, is quite sensitive and specific. But the specificity is a bit low. We'll be discussing the specificity in the later slide. But the conventional cutoff is 500 milligram per milliliter. Why is it non-specific? Because there are certain factors that can lead to potential false positive and there are certain factors that can lead to potential false negative. If the patient is geriatric, let's say 80 or 90 years of age, if the patient is pregnant, if the patient already has malignancy or recent surgery or trauma, liver disease, infection or rheumatoid arthritis, there can be elevation in the D-dimer, which might lead to false positives. But if the patient is already having a DVT or pulmonary embolism, and if the patient is already on warfarin therapy, or the patient has had long symptoms, or if the clots are small, then the elevation won't be large enough. So after our rule out criteria, after we are suspecting, if we are quite sure that the patient is suffering from pulmonary embolism, we go for a CTPA. Here we can see there is a large thrombus here, which is blocking the right main pulmonary artery. So why do we go for CT angiography? Mainly because it is widely available, sensitivity and high diagnostic sensitivity. Because of that, patient needs to lie down for a short period of time relatively, and there is, although a slight risk of contrast nephropathy, adequate hydration can take care of that. So I have this echocardiography video here. Here, as we can see, to those who are not usual users of an echo or point of care echocardiography, this is the left ventricle, this is the right ventricle, this is the left atrium, this is the right atrium. As we can see, as I mentioned before, the right ventricle is much larger than the left ventricle. The left ventricle although is more muscular, but the right ventricle is dilated. So this gives us a very good clue, and it is easy to do and it is fast to do in the bedside. Now, let's say we have diagnosed this case as pulmonary embolism, and it looks massive. The right ventricle is dilated. Patient is having dyspnea. What can we do? Or we have diagnosed DVT, and we have ruled it as submassive or a small DVT. What can we do? So there is this bifurcation of treatment. One is an aggressive treatment where you either thrombolize the patient or go for a thrombectomy. I would like to take this opportunity to tell everyone in attendance, it gives me great pleasure to say that mechanical thrombectomy is available now in Manipur, and it has saved lives. It has saved lives of my patients. So I'm very happy about that. Because if thrombolysis is contraindicated, which will be coming later on, then thrombectomy is the only way to save the patient. We can be using enoxaparin, low molecular weight heparin in low-risk patients. Or we can use newer agents like dabigatran, rivaroxaban or apixaban. They are the new agents that are factored in a antagonist. They are better than warfarin. Less need of monitoring, less side effects, just as effective as warfarin. So how do we choose the low-risk groups? There is something called a Hestia criteria. If the patient has a relatively normal blood pressure, more than 100 millimeter of mercury, systolic, no active bleeding, patient does not require O2, and is maintaining saturation over 90%, there is no pain, and there is no other medical or social reasons to admit. Social reasons like there is no caregiver, patient is alone, patient is at a old age home. So there are social factors. Thrombolysis, very quickly, we can use tissue plasminogen activator, TPA, or a catheter-based thrombolysis. There has been multiple studies comparing these two. Some say that catheter-based thrombolysis is better in patients with higher risk of bleeding because the dose given is lesser. Very quickly, I would like to show you a video of surgical embolectomy, which has saved millions of lives, and it is used in patients where the clot is large, the patient is very unstable, or the patient cannot go, or we cannot opt for the thrombolysis treatment. So, in this video, we can see a septal embolus being removed. So this is the embolus is coming out. It's long, it's big. And we can see how it will cause dyspnea, hypotension, all of the symptoms to this patient. IVC filter is an option, and again, it is being done in Manipur. It is available. Very quickly, I'll be going to two more conditions, which would demonstrate that palliative medicine is not only about palliation.
Dr. Sandeep, as we are running short of time, you may please conclude this session.
Sure, sir. Hypercalcemia is commonly encountered in palliative medicine. Very quickly, going through the treatment options of hypercalcemia. If basically there is only one thing to remember. If the hypercalcemia is mild to moderate, there is no need for acute intervention. If the hypercalcemia is high or severe, then there is an indication to intervene if it is more than 14 milligram per deciliter. What is immediately available to us is saline hydration. If calcitonin is available, we can use that. And if we have more time, the patient is stable, we can hydrate and give bisphosphonates to the patient. Very quickly, patient in oncology can have seizures, mainly because of metastasis to the brain. It is a cause of great concern and anxiety to the patient and also to the patient's caregiver. So, very quickly, just the definition of status epilepticus. If the seizure is lasting more than 5 minutes, or if there is no recovery of consciousness between 2 episodes, then it is called status epilepticus. The treatment options usually available to us, as we all know, the first line therapy is IV lorazepam at a dose of 0.1 mg per kilogram IV. Alternatively, if it is not available, we can use diazepam, 0.15 mg per kilogram IV, up to 10 milligram per dose. If it is, again, excess is available, or if there is time, we can also give phosphonate, valproic acid, levetiracetam, for which the doses are given here. Basically, if a patient comes to you with seizure, I would like to reiterate that first rule out hypoglycemia in this patient. Get a quick RBS done, and if the patient is a palliative patient, instruct the family members that what they can do is put the patient in recovery position and make sure that the patient comes to the emergency room or to the department as soon as possible. Thank you very much.
Sandeep, thank you. I know we had some shortage of time, but in between we had discussed a wonderful topic, one of the most common palliative emergencies that we often see, especially in oncology. Thank you so much. Now the session is open to queries, questions and comments from the delegates. Can you have both the speakers on the dais, please, so that we can have some discussion, a few minutes of discussion and interactions.
Good morning to everyone. First of all, I must congratulate the speakers for excellent discussion and the level of topics that was presented. Very nice. We practically in the field we have not got very much experience on pediatric palliative care, but I think it is in the offing and we will have to deal with those cases, and we are very happy that we could have some insights into that. Regarding emergency palliative medicine, what we practically face is something that I want to discuss with Sandeep, because these patients, what we face is are bedridden, they cannot be transported. One young fellow, he's around 65, 70 kgs probably, he must be weighing more than that, around 80, the look, because we have not weighed him, we cannot make him stand, he's paraplegic, not paraplegic, quadriplegic. So we cannot make him stand, but we cannot weigh him, so we don't know. But he's on the second floor, and there's a very narrow stairs, like that. So he cannot be brought down for an emergency to go to an emergency hospital anywhere. We have got to do something what we have to do there. Now he has got this bed sore which has suddenly bleeding severely. So this is one scenario that we are getting. Another is the patient who has been bedridden, very principal of a college who has been bedridden for nearly now 12, 13 years and on catheter. And in the night, the caregiver informs that the patient is having a lot of distress because he can't pass urine in the catheter. So, and then there is another patient with the CA lung who has been treated in the hospital and then sent home. Now, the caregiver gives a phone in the night that the patient is having severe bleeding, hemoptysis, cannot stop. What to do? These are the practical palliative care emergencies that we face, and those are the things we would like to understand what all we could do in those situations. Those are the things, because for sure they are not coming to the hospital, and we have to do something for them at that bedside. And our team rushes to those patients, and we do whatever we can, but we are not sure whether that is the best thing to have been done at that moment. So those are the things we would like to learn in these situations and then move forward. There could be many more stories which I could tell, but these are only few which I can reflect on. Could you give us some ideas of what to do in those situations? Like Foley's balloon is blocked, we cannot. Our palliative care nurse, she calls me in the night. Then she had got a call. She went there. She finds the balloon blocked. What to do? Because there's nothing at home, and we cannot bring down the patient anyway. So this is a practical thing.
Sir, as you mentioned, these are practical challenges and these are real challenges. As we know, the physician cannot be available at bedside all the time. The nurses cannot be available at bedside all the time. The diagnosis protocol cannot be laid out at all the time. Like we cannot have ultrasound available. We cannot have, regarding the blocked Foley's catheter, we cannot see what's inside the bladder, what's happening inside the bladder. We cannot go for a suprapubic catheterization at home. These are real practical challenges. Regarding the third scenario mentioned, the patient is having hemopsis. There cannot be, I think, practically a way in which we can transfuse the patient. There is no way. The only thing we can do is we can try to stabilize the patient hemodynamically, give IV fluids, give tranexamic acid if possible, and most importantly, talk to the family member. Talk about the staging of the patient, as all palliative physicians will be knowing, about what the patient himself wants, what the family members want, and effective and clear communication is what's required at that point of time. And if possible, I would like to say that if we can bring about point of care ultrasound at home, I think it might be a game changer in many scenarios that Sir has mentioned. We can work towards it as many portable and ultra portable ultrasounds are available. Many of the interventions that require hospitalization can be done, and the nurses can be trained for basic ultrasonography. Let's say if all the veins are collapsed, the patient cannot be cannulated. In the case where you mentioned about hemopsis, we can do that. Practically, these are practical things that we can think about. Or say equipping our ambulances, equipping our ambulances with more drugs, life-saving drugs, adrenaline, teaching the nurses how to give adrenaline if there are no, say, infusion pumps available, how to calculate the drip rate, how to calculate the drop rates at which we have to give initially to stabilize the patient, or how to give basic medicines or emergency medicines. This is what we can do practically, sir. As the patient cannot be, as you mentioned, brought to the hospital or to the floor. These are the only practical things that we can do. Regarding the patient with bleeding, the first case that you mentioned, bed sores with bleeding, a surgical team cannot be there, cannot come there, patient cannot be brought to the OT. So what we can do is we can instruct the family members, if the patient is on, if the family members are on call, on the line, you can instruct them to give compressive bandages. You can instruct them to how to dress or clean the wound, how to give even say orally, even oral drugs if available. Because if at all, suppose the patient complains of these symptoms at night time, what can we do? So the only thing available to us will be oral medication, because the family members won't be able to give IV medications. These are the real practical challenges. So in hemorrhage, what we can do is instruct the patient or family members to wrap the wound, if possible, in a black cloth, so that the blood is not apparent to the patient or to the family members, because it can give rise to more anxiety, it can give rise to more apprehension, thereby worsening the whole scenario. So these are the practical things, little things that we can do. Otherwise, as Sir mentioned, there is not much we can do in really sick patients. And
no, it's okay, go on.
So we'll accept one more question from the audience, and then we'll close the session.
Mine is not exactly a question. It pertains to the first presenter, Vasi. I think it's a nickname. I was told that it's a nickname. Okay, Dr. Halki, that was a fantastic presentation. I had a chance to visit the sick kids hospital and interact with people, the so-called clowns. So what's your take on clown therapy as a part of the palliative care?
Sorry, sir. Sorry, sir. Sir, I did not get the comment.
The clowns are being used in the sick kid hospital.
Yes,
I have interacted with many of them in my this training. So what's your take on it as a part of the palliative care, clown therapy, use of clowns in the hospitals?
So actually, clown therapy, sir, I also don't know so much in detail, but clown therapy, sir, I believe it's a part of play therapy, sir. So play therapy, which is evidence-based methods or non-pharmacological interventions to improve the morale of the children, which encourages children with the similar illnesses to stick together, to play together, in order to boost their confidence, in order to which will have a positive psychological impact, and therefore, sir, which will improve the outcomes, sir. Yes, sir. Mostly in cancer hospitals, sir. We have playrooms as well, sir, where all sorts of toys, stuffed toys and everything will be kept for the patient. We have boards where small tables, small chairs will be given, sir. So in that way, sir, this is all part of the studies have shown that play therapy, which also involves the clown therapy that you've just mentioned, sir. These are all evidence-based methods, non-pharmacological methods to improve the outcome, to improve the hospital stay, the experience of the patient, of the children, as well as the caregivers, as well as the families. Thank you.
Just to make concluding more of a comment from my side is I do believe that it's regarding pediatric palliative care because I am a pediatrician. I think in all around the world, I do believe many of the societies and even in India, I think GMH has introduced a module based in the newly inducted pediatric fellows. Those who are trained in pediatric oncology services, those who have been newly inducted, they do undergo a module where they have divided into stage 1, 2 and 3. And those trainees have to compulsorily attend and then kind of get a passing mark on that, just to be able to identify, treat and be an integrated part of the pediatric palliative care. And way forward, I do believe that not only the pediatric oncology, I think some of the areas where, specialties where we deal with palliative care, we also probably time will come when we may have to include those sorts of short modules where the physicians are being trained and they may get aware of the palliative care, the critical aspects of palliative care. Any remarks?
Yeah, just in addition.
On addiction, for Dr. J's patient, we can use this one, Botropes tablet at home. You can just crush it and just apply it.
Locally
it will
apply.
work. Yes, sir. Locally apply. It's hemocoagulase. It will block. So we have used it in emergencies for tooth bleeding, nose bleeding. Just apply it.
Good idea. Good idea.
Yes, sir.
So, in addition to the module which you've mentioned, so many institutes have come up with their own modules whereby the residents or the professionals have to undergo training in that. So, similarly, sir, the project ECO, which I've just mentioned, sir, so that we all, as residents, all the residents, palliative medicine residents, we had to undergo that 1-year training, sir. And in fact, that is open to all healthcare. It can be even nurses, even physiotherapists, even students, medical students, MBBS students can also apply for that. Where, sir, there is a case-to-case basis training, sir. Then we have lectures as well. So it is free of cost. So if anybody would like to know more about it, I'll be happy to provide the information.
Oh, wonderful.
Hello.
Sir, exactly that's what I was talking about. As ma'am has pointed out, oral-based therapy is what we are left with, sir. Because the patient cannot be attended by a physician, suppose at the middle of the night. So as ma'am rightly pointed out, oral-based therapy and tablets are what we are left with.
Locally, please talk about local.
Yes. So we can use locally.
But those are,
hemocoagulase.
those are the things we are left with, sir.
Yeah, Dr. Sandeep and Vashi, nice presentation. As a neurosurgeon, we are nowadays we are facing lots of stroke patients, and we are managing them. And even after managing, we are sending the patient for further rehabilitations. sometimes in rehabilitation centers or at home also. And sometimes we get calls from regarding the tracheostomy site bleedings and such emergencies. So I think for stroke patients mainly, we are getting this tracheostomy site bleedings. So I think that is also one of the emergency at home which we can manage. So we have to, sometimes we teach them how to deal with the bleeding. So that's one point I want to add.
I think if there are no comments, we would like to close the session here, and I would like to thank on behalf of the chairperson, we have to thank both the speakers for their wonderful presentation and the delegates. Thank you, sir.
Once again, thank you all. Thank you all chairpersons for that interactive session and the esteemed speakers for widening our knowledge on pediatric palliative care and about the emergencies in palliative care. So now I would like to request our chairpersons, Dr. Sonamani, Dr. Gautam CH and Dr. Anil Methe to felicitate the esteemed speakers of this session. I would like to request Dr. Versi and Dr. Sandeep Anandban Singh to receive this token of appreciation. I would like to request Dr. Sandeep Anandban Singh to receive this token of appreciation. Now I would like to request Dr. Jugendra Singh, Vice President, Palliative Care Society, Imphal, to felicitate the chairpersons of this session. Once again, thank you all. Now moving on to the next session on palliative care at Health and Wellness Center and Home. I would like to request Dr. Somorkanda Soram, Senior Consultant General Surgeon, Dr. K.H. Palim, Chairman and Managing Director, Shija Hospitals and Research Institute, and Dr. Ajit Naoram, Head of the Department, Physical Medicine and Rehabilitation, RIMS, to come on to the dais and to chair this session.
We would like to request Dr. N. Subudha, Co-Chairperson, Pallicon 2023, to please come and chair the session. Thank you, sir. We would like to request the chairpersons to take over the session. Thank you, sir.
Good morning. The next session is put in this program is very interesting one. It's not much about Peter, hello, yes, it's working. So the topic we will discuss is about the palliative care in the home and healthcare centers, wellness center, health wellness center and home. I will call upon Pooja Kojam, the senior resident of the community medicine RIMS, to talk about the community participation in palliative care. Pooja Kojam, please. If the mic is okay.
Thank you, sir. Good morning to all the respected dignitaries and delegates of Pallicon 2023. I am Pooja Koijam, Senior Resident, Community Medicine Department, RIMS. So I was given the chance to have a short talk on the topic, community participation in palliative care. The context is, it is estimated that 0.4 to 0.5% of the population need palliative care. And in Manipur, that translates to 15,000 people. So how can we reach those 15,000 people with the resources that we have? The only viable way to reach these people is through primary health care. To talk a bit on primary health care, PHC care is a whole of society approach to health that aims at ensuring the highest possible level and well-being, and their equitable distribution by focusing on people's needs and as early as possible along the continuum from health promotion and disease prevention to treatment, rehabilitation, and palliative care, and as feasible to people's everyday environment. This definition has changed a lot from what we first thought of palliative care, of primary health care. So once we entered into the 20th, 21st century and we are aiming for universal health care towards our SDG goals of 2030, we have become a bit more specific. We are now outlining where are the things that we want to work on. So with primary health care, we have 4 pillars. We have equitable distribution, we have community participation, intersectoral coordination, and appropriate technology. And for today's presentation, we are going to be mainly focusing on community participation. Community participation is the involvement of people in a community in projects or programs to solve their own problems. But before we delve deeper into this, we have to know what are the levels of participation that a community can have. So first, we have information, the first level of participation. Second, we have consultation. Third, we have collaboration. Fourth, we have empowerment. And last, we have decentralization. We have to remember that when we talk about participation in this case, it can be thought of from an individualistic point of view, from the community point of view, community as part of an organization, the organization, and the organization along with the government. To talk a bit more regarding these levels of participation, so in the stage of information, the public or the level of participation is a bit non-participatory, which means the decision is made by the decision makers at a higher level, and all they're doing is conveying of information as adapted and presented by these decision makers, either to the community or to the public. Second, with consultation, members of the target groups are being consulted, but they have no control over whether their views are considered or not. collaboration, it's where the sentiment of true participation starts, which means they are having a guaranteed role in decision making. In empowerment, the entity, the community, or the individual, the organization has been given independent decision-making power, but they do not hold accountability at this level. The decision which they make, the accountability goes over to the government. And this is the result, the interventions, the solutions that come up is a result of a participatory developmental process. And last, we have decentralization. So it's the top level which goes beyond empowerment, where we add accountability to your decisions, accountability to the solutions taken and being implemented, and all forms of self-organized interventions which is initiated by the citizens themselves from the beginning fall under this. So to give a brief example of these levels of participation, when we talk about information, so we have many different delegates coming here today. We have lots of learned people. At the same time, we have people who are just going into the field of palliative care as well. So for our volunteers, the students who want to know about palliative care, who heard about Pallicon and who have come here to know more about that, the level of participation which they have is at the level of information. They want the knowledge, the skills regarding palliative care. In terms of consultation and collaboration, what one of our NGOs, our PCSI, is having with the government is at that level. We cannot, or the society, the Palliative Care Society in Imphal cannot take policy making decisions, but at the same time, they can make shared decisions with the government as to what is required regarding palliative care in the state of Manipur. And last, we have empowerment and decentralization. So certain activities of, as we said, the example of PCSI, certain activities like the home-based care, going and sending of the professionals, the health professionals to the home and all, this is done on their own level. That decision is taken by them and is not hampered by any higher authority. So that is the level of empowerment and decentralization that we're talking about. And the society holds accountability for making those decisions. Under the aegis of any government or any organization, the next step forward from the levels of participation is to create a community-based palliative care. And in order to create this, it always starts with awareness, with information, with sensitization. We need to make them aware what is needed. We need to know. Second, we have training to train them on what is required, and along with training, the core values and the ground rules of what is to be done, what not to be done, what to be considered is also taught. And then we have engagement. Once you have the knowledge and the skills, the next is to perform it, to demonstrate it, and if you can do it well, to perform it. And then we have periodic reviews, which means whatever we do, it should be always in a cycle of updating. We should always be updating our knowledge, updating our skills. So periodic review is important for that case. In the state of Manipur, as of now, we do not have community-based palliative care units in all the communities, but each of the nodes that I have said is an activity in itself. So we are doing awareness, we are doing training, we are doing core values and ground rules, and engagement in care delivery, along with periodic review at different levels of the community, involving the community. So some of the examples I'd just like to share. For us, as our department, Community Medicine, we have been giving awareness, especially to school students. This was on the day of World Alzheimer's Day, and here we were talking about palliative care to the elderly. How can you, as a grandson, as a granddaughter, how can you help the community? And at the same time, we are also doing research works as to what are the needs, what are the demands, or what is the gap that are there in the community with regards to palliative care. Then with PCSI, they're having home-based care visits, as they said, OPD consultations, online consultations, and at the same time, training. trained even to us. So we had the opportunity to have a workshop for palliative care in 2021, where we learned a lot more regarding palliative care from PCSI. And then our health and wellness centers in the community, they are also providing home-based care and OPD consultations in Manipur, and it is still going on. So even though all these are going on, we are unable to set up, or we do not have enough to set up a community-based palliative care unit in each and every community in Manipur. So to talk about this, I like to talk about a quote. So culturally now, we are really tight around death. And as a result, I think people miss out on a lot of the beautiful aspects of the end-of-life process that can be very helpful for the grieving process. That can be really beautiful part of transition of life that we don't get to experience because it's not in the conversation by Christabel. And this, we talked about it in our, on the previous day, engagement in dialogue, engagement in conversations regarding death. We won't be able to move forward with palliative care and how we want the community to be engaged in palliative care, how we want them to have their own initiatives regarding palliative care, unless we engage in dialogue. Conversations is always the start. We need to start talking about death. We need to start talking about how we want it or why we want it like that. We need to have open conversations regarding death, and only then can we transition more from all the notes of palliative care engagement that we are doing right now in the community to later setting up that community-based palliative care unit. So with this, I end my slides. Thank you.
Thank you, Dr. Pooja Pujan, for your precise and a very short discussion about this community participation in palliative care. We are lacking in this product community participation in palliative care, as everybody knows. And the government is aware of the shortcomings and is trying to make up the deficiency. Before I invite questions, I will suggest that we discuss about the issues in the questions and answers after finishing the second paper. The second paper is a very interesting one, a spiritual one, and the issues are spiritual issues in palliative care, and it will be presented by Professor R.K. Lenin Singh, Department of Psychiatry, RIMS. Dr. Lenin, please.
We have a great orator for the next presentation. Dr. Lenin does not need any introduction to the people of Manipur, but for the benefit of everyone here, Dr. Lenin is head of department and professor, Department of Psychiatry, RIMS, and he is also president, Indian Medical Association, Manipur State Chapter. Dr. Lenin, the floor is yours, please.
Good morning, and thank you, Cheers, for your kind words. To begin with, I would like to declare that I am not an expert in spirituality, but I do believe 100% in spirituality in every breath we take and in every activity we do from birth to death. So in my mind, spirituality issues is not only in palliative care, it is in everything we do. And providing spiritual care is nothing but providing peace and providing solace. Or rather, if they awaken, if the urge for peace and tranquility and solace from within, that will be the best awakening one can instill in someone's mind, and that will give in whatever stage of life they will be happy with themselves. That should be the ultimate goal. That is what I believe. When do we need palliative care? That we were talking since yesterday morning, and in fact, when we have lost all the possible ways, means, and technologies that complete cure, that's what we used to talk about in the past. Nowadays, we talk about control, maintenance, sustenance, prolongation, quality of life. That is a change in the vocabulary in the medical science. So in this new era, what we need is to enjoy the moment, the situation where we are, and not to complain, not to bargain, not to feel guilty, and to accept yourself as you are in that situation. Is it possible for all of us? For me, I need to struggle in this regard. I think many of us will also be doing the same thing. Every day when we come across a crematorium, it does not come to our mind that one day we will also dwell in this situation, in this environment. But only when the death sentence, or so to say the bad news, has been sort of unexpected and unwanted situation arrives or inform to that individual or family members, then we think about, introspect, that one day everybody has to go through this procedure, and as it was discussed earlier also, that ultimately that is part of our life. And it is also said that our life cycle is not complete without death. We are mortal beings, so our cycles with birth and continues our life, whatever it may looks like, but at the end, it has to complete the circle by death. So we are supposed to enjoy the journey and also accept the inevitable, which is the sign for each and every one. Why should we complain about that? And why should we regret about that? So my short talk, I have collected some information and my own experience. I would like to arouse some thoughts about the esteemed delegates of today's hall. I'm not an expert. I'm repeating because of the last word only, but let me go through this definition of WHO. Palliative care is an approach that improves the quality of life of patients and their families. The second part is very important. We usually neglect the second part. Facing the problems associated with a life-threatening illness through the prevention and the relief of suffering by means of early identification, impeccable assessment, and the treatment of pain. Pain comes very significantly in the palliative care and many others. And other problems includes many things. It may be physical, and many a time it is psychological, and also it is social. Who will look after for so many years? He is bedridden. Many examples have been given. And the psychological impact of the severely demented parents and grandparents. How do you feel when you look at them? When you visit them, they even do not recognize you. Then what will be your emotional status? So the family members do also need palliative care, especially in the form of psychosocial and spiritual input. So the definition of palliative care ends with a very important word called spiritual or spirituality. There lies the importance of spiritual inputs in the holistic approach of palliative care. Now, it is very difficult to define spirituality. I understand what do you mean by spirituality, but if you ask me to define what is spirituality, it is very difficult for me, especially in my local language. If I am supposed to talk to my patients, family members, to explain or to convince about what do I mean by spirituality, it is not an easy task for me. But nonetheless, we have to define to go ahead with this approach. I borrowed the definition from Pusalski et al., which was given in 2014. It says, it is the aspect of humanity. Humanity comes in a very important word in this definition. Humanity, it itself is also very difficult to define, but all of us understand what we mean by humanity. That refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, and to others. There are three different things we are talking about. We are supposed to be connected. Connected to whom? Connected to what? We are supposed to connect to the moment I am living now. I am connected to this moment when I am talking to this August house. I am also connected to self, means what I am doing I understand. And also to the others, means our audience and the environment, and to the nature, to the significant or sacred ones. So this is connectedness. When you are distancing yourself from the reality, there lies the problem. When you are accepting and immersed into that reality where you belong to at that particular moment, that is called mindfulness, in other words. That is the in thing now. In every aspect, we usually use this technology or technique rather in managing many of the neurotic domains like anxiety, depression, stress, and adjustment disorder and all that by using mindfulness technique. Spirituality plays an important role at the end of life, but as I said, it is not only at the end of the life, it is very essential during the course of our life also. Life cycle, as I have mentioned, is incomplete without death. That is a very, very important part of our life cycle, but usually we are trying to run away from this inevitable event rather than accepting, and like our Dr. Puja has said, we are supposed to have dialogues when we are alive, strong, healthy about the last moment as well. Why you are neglecting the inevitable? Spiritual care is all about allowing people to heal from within. We are putting balm on the outside. Okay, that will suit the skin and pain might be relieved, but in spirituality, what we do is from within. Healing from within. That is not easy, but it is very calming and it will give a very, very long-lasting solace. All the religions, when we talk about spirituality, usually we take it synonymous with religion. But religion, all the religious activities are spiritual, but all the spirituality is not always religious. There are other aspects of spirituality other than religion. Religion is a different aspect which is followed by a group, and they have a set of rituals, beliefs, activities, and they strictly follow that, and it gives immense healing effect to each and everyone who honestly and earnestly believe in that. But in the extreme cases, it might also create enmity, groupism, etc. that will be very counterproductive and also do harm than heal. So the other spiritual activities we will just mention in a later part of my presentation. Spiritual well-being was associated with higher rates of physical, emotional, functioning well-being and better quality of life. Even a person, we cannot believe, having the severe pain of the terminal stage of cancer might enjoy his life, her life, if we strictly believe, follow, indulge in this spirituality. Pain is also part of our life, but it's not easy to digest. The process of spiritual struggle is a normal reaction to life changing events like being confronted with a life-threatening disease. There we talk about the how to communicate the bad news about the serious illnesses, about end of the life diseases, about the chronic conditions, about the accidents, about the disabilities, about the prognosis of bad prognosis of certain disorders. From there onwards, we can incorporate the spiritual component from that point itself. Aim of spiritual care of palliative patient is to reduce demoralization and increase resilience. Most of these patients have a tendency, first will be shock, then they will withdraw, they will become dumbfounded, and later on they will try to surrender, and that will be the most dangerous challenge to keep them healthy and to prolong their life, because they are not participating in the process. So that's why we are saying giving them hope, giving them peace, giving them solace, and also hope for enjoying those very, very precious moments left with them. Why should we spoil those precious moments if the death is inevitable? That is a very important question. But many of us do not think about that, and we waste and we suffer those precious moments as well. There is something called spiritual crisis. There is very similar to our psychiatric disorders like depression, stress, adjustment disorder, etc. It is defined as an acute and profound questioning of self. Why I was born? What is the ultimate aim of life? If I am going to die after a certain period of time, why should I be sent to this planet? All these things, different questions. And we asked about the meaning of the world and or the transcendent by external stressors in which an individual reaches a turning point or crossroad leading to a significant alteration of the way of life and the world are viewed. Their previous perception and concept and the meaning of everything might get changed towards the negative aspect, and even some people consider going about committing suicide, and some people attempted and some people even end their life by suicide. So this is a very important critical juncture. Not only pain relief will help in this juncture of life. We need more than that. So there is a cycle when there is an increase in physical and emotional symptoms, like we usually take about the terminal stages of cancer or chronic kidney disease or whatever you can say, or even the normalizing process when they have become very vegetative. There might be pain, insomnia, restlessness, trouble in eating and voiding, etc. So it will lead to unmet spiritual need, that they need solace, but which is not coming from any angle, and especially from inside. That will lead to spiritual distress, resulting in fear and dread. They are very fearful and they are feeling very guilty. So we need, after talking this much, we come to need for spiritual intervention. But do all of our palliative care patients need spiritual inputs? No, some people do not want it. So we have to respect their choice. And those who expressed or whom we try to perceive that they will be helped by spiritual input as well, that we have to find out. But how do we find out this? It's not very easy. So assessment is how, there may be some indirect questions. There are many checklists or many screening tools are there, but in a terminally, it depends on the client also. They are active, they are alert, then there is something else. They are down, then we can even talk with the patient party also, family members. They can also give some clues. How do you make sense of what is happening to you? Whether they really understood what they are in now, from what problem they are suffering. In some of the cultures and tradition, we are very scared to take away the hope from those persons. For example, if my family member, someone's family members, is diagnosed as a very malignant cancer, in that case, they will come to the doctor and say, please don't disclose the diagnosis to my near and dear one. Okay? That will kill him or her faster than the natural course of the disease. That is because his or her hope will be destroyed. So that is in some culture. But in some culture, let them know and let them plan the later part of their life, and also that let him or her find some ways to enjoy the last few days or weeks or months or years of their remaining life. So it depends on the culture, and we have to respect that also. What source of strength do you look to when life is difficult? Many a times when real situation is very, very worse, then we go towards God, many of us, or the Supreme Soul, or something which is unseen and which is big, very big, and which can help us. So this is usually what we do. Even the scientists, when they are going for moonwalk and all that. Would you find it helpful to talk to someone who could help you explore the issues of spirituality or faith? Are you interested to talk about some religious things? Are you interested to talk about some spiritual things? But as I said, it is difficult. You have to explain, rather than we don't have a particular word for spirituality. There is one tool that is called hope. H-O-P-E. H is source of hope. From where you got the source of hope for anything in life, including these days. That meaning, comfort, strength, peace, love, and connection. From where? My grandson, my dog, my wife, my spouse. It might vary from person to person. Or my God. Organized religion. Do you have an organized religion? Are you belong to some religion? Many people do. But nowadays, many people say, I don't believe on any God or any religion. This is also coming up. So personal spirituality, are you interested or are you inclined towards any spirituality or spiritual activities? E is effects on medical care and it should be N, not A. Issues. In this terminal phase, are you interested to dwell in such topics? Another one is called FICA. This is spiritual history tool. Why I am sharing this? Because it is not easy to assess whether the person is really interested or it is spiritually inclined or not. We can, starting de novo, it's also possible, but it will be different from what the person is at that point of time, at the spiritual level of understanding and involvement. Next is how to approach. Approaching them and your calmness, your attitude, the way you smile, the way you talk to them makes lots of difference. So listening actively, listening attentively, listening very lovingly, that will start the day. It should be non-judgmental. Whatever they say, don't argue and accept it as it is. Unconditional interest to help. You will not gain anything out of that interaction or discussion that will increase the value of your visit or meeting. Caring attitude is very, very important. Once on spiritual well-being and resilience, if yourself are not very strong enough in the spiritual world, spiritual beliefs, spiritual practice, and also you don't have any resilience. Resilience, in other words, you can say it's about the coping skill of yourself. If you don't understand your mind, how can you read the mind of the other people? So first, if you have lots of love, then you can share the love with others. If you have lots of energy, then you can share it, part of it, to others. So if you are very poor in love, in the spirituality, and in your energy, if you have lots of negative vibrations, then you will spread only negative vibration, not positive vibration. So be yourself first, be strong in spirituality, and have a good resilience. Listening contents of the history. When they said one sentence, I can interpret in different aspects of different parts of the history. I will give a small sentence which is given by 41 years old lady. who is bedridden, not bedridden, is hospitalized in the bed for chemotherapy. So she meekly shared with the palliative care person, saying that it seems like I will not be able to be at home with my 4 children this weekend. Means there are different components in this short sentence. The first one is factual. Factual means the physical location, that what she is into, what diagnosis she is in, what stage of treatment she is in, is been expressed here. Emotional, when you hear that, it cannot be without emotion. It contains lots of love, sadness, longing, and regret that I'm going to leave my children. I love my children. I'm sad that I'm going to part with them. I would like to continue these many weekends more. That is the meaning. And biographical means she is the loving mother of 4 children. And what is the spiritual component in this? So what is the spiritual component? Is the most, what is the most meaningful in her life? The most meaningful in her life, according to this statement, is the 4 loving children. So that values she gives most in the 4 children. Every mother usually do their most important meaning of life is their children. So, competency of the palliative care personnel will be capacity to reflect the importance of spiritual and existential dimensions of the patients and their family. Number 2, you should be able to integrate the patients and family's spiritual, existential, religious needs in the care plan, because it is very, very supportive and it will be sometimes backbone of the healing process. Provide opportunities for patients and families to express the spiritual and or existential dimensions of their lives in a supportive and a respectful manner. And the last, be conscious of the boundaries that may need to be respected in terms of the cultural taboos, values and choices at this very, very critical moment of life that we have to follow. We should not impose our own values and morality. We should follow, we should respect rather the cultural taboos, beliefs, values of that particular individual and their families. So there are many types of spiritual inputs or healing. Number 1, most common, we all follow is the religious one. There are religious norms, beliefs, practices, and reading religious or pious or spiritual books. This is usually we do. We have in olden days that we have Mon Shiksha, that means teaching the mind or soul about death and how to accept death without fear. And even that Nonga Isai, that how and why you are going to end this life after a fruitful or productive decades. That's what. And there are many rituals, there are many when the person is very sick, especially when they are the normalizing process, all these things are planned by the family members and the meeting with the all friends, sharing with their all memories, the nostalgic events and all that. These are all can be included in the form of spiritual healing. Number 2, others, those who are not religious persons, then also we can provide some spiritual inputs like mindfulness, as I have briefly mentioned. Meditation, it's very easy to say but difficult to practice. It's not easy to meditate. It needs practice and training. Yoga, it's a very in thing, easiest and more practical. We can take up. Even the creative interventions can be considered as a spiritual healing, because music and art that is touching the soul and the heart, if you really indulge in that. So this is also part of it. And some people do expressive writing, that express what they feel, what is the pain and what is the expectations, etc. Keep reading, keep writing. Dignity therapy is what you are, what you have done, what you have contributed in this universe, and it is not a wastage that you have come to this earth and you have lived this and that, sort of. So dignity is very important. Even when we talk about in forensic, dignity of the dead cadaver, dead body, is also talked about. So why not in our life and also the precious terminal phase of our life, we should have our own concept, perception of dignity. There is a construct called dignity therapy. This is also very useful. And even when we do social service, helping other people, the pleasure of helping, pleasure of giving, this also the art, this also, even in the highest form, it can be considered as a spiritual activity. So all these things, if you are religious, it is already, yes, already you have a well-defined structure and rituals and all that. If not, we can take up any one of these. Thank you very much for the active listening.
That was a wonderful presentation, to say the least, and we would have liked to carry on and on, but because of time constraints, we have to shorten. Now, I think we can take a few questions. So we invite Dr. Pooja also to be on the dais, and I think we can take a couple of questions from the audience. Someone, please.
I am
No problem, please.
I'm Dr. K.S.H. Mangle, now President of PCSI. Formerly I was Chief Medical Officer, Thawal District, Undivided Thawal District, and later on Undivided Imphal East. I retired as a medical officer. See, in fact, in my service period, I had a double life. Probably we may call it Jekyll and Hyde. I was doing post-mortem examinations and other medical legal examinations after getting the postgraduate degree in MD forensic medicine. Then I was given the post of Chief Medical Officer in these districts. What I feel now, we are discussing at length about implementation of palliative care in a big way. But we are lagging behind in some of the policies, I should say. Some of the medical officers, community health officers have been trained in palliative care by our doctor, who is the director of Institute of Palliative Medicine, Kerala, and who is none other than Dr. Suresh Kumar. He has done a big service to this area. But what I feel is that the district level officers are not yet trained so far. This is a big gap. When we started our multi-purpose worker scheme in the districts many years back, we were trained outside Manipur to get this knowledge so that we may be trainers for the training. And in some other national health programs also, we were exposed to training outside. But in palliative care, what I find is training is done at the grassroots level, not the higher-ups. The medical directorate as well as the district level officers, so many officers there, leprosy, malaria, then of course NCD nowadays, blindness, control, everything. So they are not exposed to this subject. And if they are not well versed with this subject, how can they supervise? How can they look after? Even leprosy patients, debilitated, incapacitated patients who are lying in their homes, they are very much required for this palliative care service. So my suggestion is we should pick up these higher level officers for getting the training so that it may be given more strength to this system. Again, we have seen many health and wellness centers in many villages when we go around. But whether they are doing the work properly or not, we don't know. But it depends upon the strict supervision of the district authorities. Without supervision, it cannot be complete. So supervision is very much required. Training of the district level officers, supervisory officers are very much required. This I want to comment. Thank you all.
Thank you, Dr. Mahale. I think the government policy is now to stress on the palliative care in the primary level as well as in higher level. The program is being implemented, I understand. I invite any more questions, one more question from the audience if there is. Dr. Vijendra, please.
This is, I think I can be heard.
Yeah.
Okay. This is working now. So thank you so much, Dr. Lenin, for that topic on spirituality and palliative care. It is very important for us. The ground level when we are doing home-based palliative care, this is a big issue. For the audience who are hearing this for the first time, I would just like to give a few pointers for a practical purpose in palliative care, spirituality in palliative care, because they may this need this microphone needs palliative. Is there a microphone there?
Come up to the dial.
Sorry for that. I just want, because there are young students here, I would like them to carry the message about spirituality in palliative care. Is that when do you know that a person is having spiritual problems? When the patient starts asking questions like, why me? Why this is happening to me? When he starts asking that question, it is related to his spirituality. Then when he starts thinking, where did I come from? And after this, where am I going? These are the pointers that he is thinking about his spirituality. And it is very difficult to answer these questions. It is not easy, and you have to really be in their situation and then try to understand. But what I would like to ask, impress on the youngsters is that please do not make any comments which may make them feel guilty for their own situation. They may be having their own questions that this is because of my karma which I have done, I am suffering all these things. That is their thought. They can entertain that thought. But if you as a caregiver or your own relative, somebody is there who is very sick, Please don't do that. That is totally against our palliative care principles. You should not make them feel guilty for what their situation is. This is one thing. And another thing, please don't impose your beliefs and practices and religious tendencies on the patients. This is the message I would like to give, because it may be totally different. I may be talking about God and so many things to the patient, but the patient may be a person who does not believe in God at all through his entire life. And so it is totally useless at that moment of time when he is going to die to talk about God and to convince him that it is God's natures. So it is very individual and very this thing. So you have to be very careful on the spiritual aspect, because that may turn the care to a very different direction if we are not careful of these small things. This is just the comment I wanted to pass. Thank you, Dr. Thank you.
Since we are running behind time by almost 1 hour, I'm sorry, we cannot take any more questions. Thank you, Dr. Puja and Dr. Lenin, once again for the beautiful talks. I think we'll conclude the session now. Thank you.
Once again, thank you all the chairpersons and esteemed speakers for enlightening us on importance of community participation in palliative care and spiritual issues in palliative care. I would now like to request Dr. N. Subodha to kindly felicitate Dr. Pooja Koijam. I would like to request Dr. Samukanta Soram to please felicitate Dr. R.K. Lenin Singh. I would now like to request Dr. Suresh Kumar, Director, Institute of Palliative Medicine, Kerala, to kindly felicitate the chairpersons. Thank you, sir. Thank you, sir. Now we will proceed forward for a short tea break, and let's assemble again at 11:30. Okay, we'll start.
Yeah, let us start. Those who want tea, they can go and have tea and come. Just start.
Okay, we'll move on to the next session.
Yes.
We can now move on to the next session on volunteerism in palliative care, and we have a panel discussion on the role of volunteers in palliative care. So for this, I would like to request the panelists, Dr. Suresh Kumar, Director, Institute of Palliative Medicine, Kerala, and Madam Saroj Nagni, Palliative Care Society Institute, Manipur, and the representatives of
Mamba, Indian Red Cross Society, Doctors on Pedals, and Dr. KSH Manglim Singh to kindly join the panel discussion. For this panel discussion, I would like to request Dr. Gautam Soram to moderate the panel discussion on role of volunteers in palliative care. I would like to request representative of Indian Red Cross Society, Dr. Arun, to kindly join the panel discussion. I would like to hand over the mic to Dr. Gautam Soram to kindly moderate the panel discussion. Thank you.
Thank you, Dr. Avantika. Once again, a very good morning to all. I think she forgot to call out one of the representatives for the panel discussion. Please, representative of Rotary Club Imphal, retired Pramod Kumar Chavra, past President Rotary Club of Imphal, Rotary International District 3240. Once again, I welcome all the panelists for this very important session. The topic for today's panel discussion we have kept is role of volunteers in palliative care. So all the different organizations have been doing so many activities, but since yesterday morning we have been talking about palliative care, the different aspects of palliative care, different modalities of delivering palliative care services to the people, and the role of different stakeholders. And when we talk about different stakeholders, the different organizations, or we can say volunteers, we feel looking into the activities or the success stories of other states, these volunteers have a very vital role to play. And so, as in our state, Manipur, we are struggling to make these palliative care services available and accessible to all. We felt like we should be organizing such type of panel discussion. So to begin the session, I would like to put the first question on the most experienced person amongst the panelists, Sir Suresh Kumar, Director, Institute of Palliative Medicine, Kerala, who has an experience of more than 30 years in this field of palliative care services. And the first question I would be putting to him is how their institute, the Institute of Palliative Medicine in Kerala, are functioning along with the volunteers. Who are these volunteers and what are the roles you have been assigning them and who are the potential volunteers? So you please put some light on these matters.
Okay, thank you. As you mentioned, we have been working with large groups of volunteers all the time, fairly big numbers, from different categories. Like they are young people, retired people, there are people housewives, there are people educated, well-educated people, not so well-educated people, artists, So the way we approach it is one thing that we keep in mind is that the volunteer is not working under you. The volunteer, because you are not paying you are sort of, it's not hierarchical, they are working with you. So the volunteer gets the full, when they come, or when they start working, when they work with you, they realize that okay, they are not under you, they are people with independent spirit, and then that is freedom to work. And then what you usually suggest to them is when somebody approaches you, what you usually ask them is sort of put them the full list before them. These are the things that we do, this is what the patient needs, and do you think that you will be able to help any of them with you in your present capacity and time, or do you need training in any of the other activities? As a routine, we offer a 16-hour baseline training to all the people who want to do volunteering, but in addition to that, we recognize it. I think this is the most important thing, and we never substitute clinical care with the volunteer care. Like the volunteer is not asked to substitute for a nurse. The nurse has to do his or her own duty, and the volunteer has to do his or her own duty. This is something. And the third one that we learned over the time was that we don't pay the volunteer. No remuneration at all, because we keep these as two separate streams. Paid work is something, and volunteer work is different. Because once you start paying even a small amount, we had that problem initially. And then volunteers start to compare their work and their payment with the staff, and also ask for further payment. So we have been keeping this as two separate streams. Absolutely no payment. We facilitate, we train them. So this is one area, and then so we have been managing.
Thank you so much, sir. I think with that information from Sir Suresh Kumar, our other panelists also have a little idea about how these volunteers are involved in the palliative care services in the state of Kerala. Next, I would like to put my question to Ma'am Saroj Nalini. Ma'am Saroj Nalini is a retired teacher, and she is a senior citizen and a member of the Palliative Care Society Imphal, and she is volunteering for the palliative care services since so many years, since the inception of Palliative Care Society Imphal. So, ma'am, please put some light on this, the services rendered by volunteers in the delivery of these palliative care services.
May I speak in Manipuri? Angapa wari amani ay ahan bagi wari si. Aina society ki damakta tahi 70 surakanda kari tawaya de na khalak pada palliative care si yan han bawai na ngonda dong jaba se biba. Tahi 70 phau se ay si imung ki thabak aduga society kari ki tappa khotpa tappa khotpa da kai ngonda ba. Aina 70 suraga de oi thadoga society cái nón tàu rồi cái đi hình dù này còn ra giảm thi chạy ta đi này hoặc khăn chỉ xài được cái gì. Adu number one I have been like the makotis pen I explain to you lady cái mamang si da palliative care si number one da agree ibu mo di do amati lo na ba palliative care di thobu e bi ba mo isa sin Lembira tana ay habben sida moina pelan gibado ay di never ay ta suta dri ay jan pina America de phone am tawrai ma palliative care mi la kanien adu ay di palliative care mo do no dre adu karino si kan khambana te adu bu patient we ba ya habben na sukki mati pi laga mana palliative care sa hayen sula ko pam mai wa khanda ay di kan te care le do da ba Lagi day by day lotion सरकार ने एक हस्बैंड थे नौगागरे अदु कांची दा इना इशोना पीरियड पर गुम 16 की Pallicon की केनो अमा इमा होल्डा तो वैसे दा मेंबरशिप लोग जो है एक चारों जग शासना तो भी मोई लेबी रखना अदे की ऐसा लगे नोई की सेवा से ऐसा लगे कई नोई दा ऐ हस्बैंड मतलब हराओ की बदो अदु अतोपा अनाबना हराव ओरगदि मागी अमु हेन पेनबा माना लाहलु नोय palliative care do ai phagani na hairamaga aina laanba ngomhida contact laitadana ꯑꯩꯁꯤ ꯅꯝꯕꯔ 1ꯗ ꯑꯩꯉꯣꯟꯗ ꯌꯥꯝ ꯁꯦꯟꯇꯤꯃꯦꯟꯇꯦꯜ ꯑꯣꯏꯕ ꯐꯤꯂꯤꯡ ꯑꯃꯅꯤ ꯑꯩꯒꯤ ꯂꯥꯏꯐꯇ ꯑꯗꯒꯤꯗꯤ ꯑꯩꯅ ꯑꯃꯨꯛ ꯑꯗꯨꯒꯤ ꯐꯤꯂꯤꯡꯗꯣ ꯀꯩꯗꯧꯔꯒ ꯄꯣꯛꯑꯦꯅ ꯍꯥꯏꯕ ꯃꯇꯝꯗ ꯏꯆꯥꯁꯤꯡ ꯌꯥꯝ ꯂꯨꯅ ꯇꯧꯕꯤ ꯑꯩꯉꯣꯟꯗ ꯑꯁ ꯑꯁꯤꯅ ꯑꯗꯒꯤ ꯑꯩꯅ ꯑꯃꯨꯛ ꯀꯣꯏꯁꯟ ꯇꯧꯒꯦ ꯑꯩꯗꯣ ꯑꯣꯖꯥ ꯑꯣꯏꯕ ꯑꯩꯅ ꯑꯅꯥꯕ ꯌꯦꯡꯕ ꯆꯠꯄꯗꯨꯗ ꯑꯩꯅ ꯀꯔꯤ ꯇꯧꯒꯗꯣꯏꯅꯣꯁꯦ ꯑꯩ ꯋꯥꯈꯜꯗꯗꯤ ꯉꯥꯛꯇꯪ ꯁꯥꯏ ꯑꯍꯥꯟꯕꯒꯤ ꯅꯨꯃꯤꯠꯅꯤ ꯑꯩꯅ ꯇꯝꯖꯔꯤꯁꯦ ꯑꯗꯨꯒꯗꯤ ꯑꯩ ꯊꯥꯡꯃꯩꯕꯟꯒꯤ ꯑꯦꯔꯤꯌꯥꯒꯤ ꯑꯍꯟ ꯑꯃ ꯑꯅꯤ ꯑꯗꯒꯤ ꯑꯗꯨ ꯅꯨꯃꯤꯠꯇꯨꯗ ꯀꯩꯅꯣ ꯑꯅꯥꯕ 3 ꯆꯠꯂꯤ ꯊꯥꯡꯃꯩꯕꯟ ꯑꯗꯨꯗꯒꯤ ꯍꯦꯟꯗ꯭ꯔꯤ ꯑꯩꯈꯣꯏꯁꯦ ꯑꯗꯨꯗꯒꯤ ꯃꯣꯏꯅ ꯑꯩꯅ ꯀꯩꯗꯧꯗꯒꯦꯕꯨ ꯑꯩ ꯑꯗꯨꯝ ꯈꯪꯉꯛꯑꯦꯕ ꯈꯨꯗꯛꯇ ꯑꯩ ꯃꯅꯤꯄꯨꯔꯤꯗ ꯇꯝꯃꯛꯄ ꯑꯩ ꯑꯣꯖꯥ ꯑꯣꯏꯕ ꯑꯩꯅꯁꯨ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔꯗ ꯀꯩꯗꯧꯗꯣꯏꯅꯣꯅ ꯈꯜꯂꯝꯕꯁꯦ ꯃꯣꯏꯗ ꯋꯥꯔꯤ ꯑꯃ ꯃꯣꯏꯅ ꯑꯩꯉꯣꯟꯗ ꯂꯤꯊꯣꯛꯅꯤꯡꯕ ꯑꯩꯅ ꯃꯣꯏꯗ ꯍꯪꯅꯤꯡꯕ ꯑꯩꯅ ꯁꯥꯇ꯭ꯔ ꯂꯣꯏꯅꯔꯛꯄ ꯆꯍꯤ 35 ꯁꯥꯇ꯭ꯔ ꯂꯣꯏꯅꯔꯛꯄ ꯑꯗꯨꯒ ꯁꯥꯇ꯭ꯔ ꯂꯣꯏꯅꯕ ꯑꯗꯨꯒ ꯃꯇꯧꯒꯨꯝꯁꯨ ꯇꯧꯕ ꯌꯥꯗꯕ ꯑꯅꯥꯕꯗꯤ ꯑꯣꯏꯔꯤꯕ ꯑꯗꯨ ꯃꯣꯏꯒꯤ ꯄꯨꯛꯅꯤꯡꯗ ꯌꯥꯝꯅ ꯐ꯭ꯔꯤ ꯑꯦꯟ ꯐ꯭ꯔꯦꯡ ꯋꯥ ꯉꯥꯡꯍꯟꯕ ꯑꯃꯗꯤ ꯗꯔꯀꯥꯔ ꯑꯣꯏꯕ꯭ꯔꯥ ꯍꯥꯏꯅ ꯑꯩꯗꯤ ꯑꯗꯨ ꯑꯣꯏꯌꯦꯅ ꯍꯥꯏꯖꯔꯨꯕ ꯅꯠꯇꯦ ꯈꯨꯠ ꯄꯥꯏꯕꯤꯕ ꯑꯗꯒꯤ ꯑꯩꯒꯤ ꯈꯪꯅ ꯆꯥꯟꯅꯕ ꯁꯨ ꯌꯥꯎꯔꯝꯃꯤ ꯑꯩꯈꯣꯏꯒꯤ ꯀꯩꯅꯣꯗ ꯕꯥꯕꯨꯄꯔꯥꯒꯤ ꯑꯍꯜ ꯑꯃ ꯑꯩꯒꯤ ꯏꯆꯥꯅꯨꯄꯤꯒꯤ ꯁꯨꯃꯥꯏꯅ ꯇꯧꯗꯅ ꯑꯩꯅ ꯃꯣꯏꯒꯤ ꯑꯦꯇꯦꯆꯃꯦꯟꯁꯤ ꯁꯨꯝ ꯂꯩꯔꯛꯄꯗꯣ ꯀꯔꯤꯒꯤꯅꯣꯗ ꯗꯥꯛꯇꯔ ꯎꯕꯗ ꯃꯣꯏꯁꯤ ꯀꯤꯌꯦꯕ ꯑꯩꯁꯨ ꯀꯤꯌꯦ ꯑꯩ ꯑꯉꯥꯡ ꯑꯣꯏꯔꯤꯉꯩꯗꯁꯨ ꯗꯥꯛꯇꯔ ꯎꯕꯗ ꯀꯥꯡꯗꯅ ꯆꯦꯟꯁꯤꯜꯂꯤꯅꯦꯕ ꯗꯥꯛꯇꯔ ꯑꯩꯁꯨ ꯀꯤꯖꯈ꯭ꯔꯕ ꯍꯤꯗꯥꯛ ꯀꯥꯞꯄꯛꯀꯅꯤ ꯑꯃ ꯇꯧꯔꯛꯀꯅꯤ ꯑꯗꯩ ꯍꯤꯗꯥꯛ ꯄꯤꯖꯔꯛꯀꯅꯤ ꯑꯩꯁꯦ ꯑꯁꯨꯃꯥꯏꯅ ꯇꯧꯗꯅ ꯃꯣꯏꯅ ꯗꯥꯛꯇꯔ ꯎꯕ ꯃꯇꯝꯗ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔꯒꯤ ꯒ꯭ꯌꯥꯟ ꯇꯥꯕ ꯈꯔꯗꯅꯦꯕ ꯑꯇꯩ ꯊꯛꯀꯠꯂꯦꯕ ꯊꯛꯀꯠꯂꯤꯕꯁꯤꯡꯁꯦ ꯑꯩꯒꯤ ꯋꯥꯔꯤ ꯑꯃꯈꯛꯇꯤ ꯌꯥꯝ ꯀꯥꯟꯅꯕ ꯑꯃ ꯑꯣꯏꯔꯝꯃꯣ ꯑꯁ ꯑꯩꯈꯣꯏ ꯐꯗꯣꯏꯅꯤ ꯑꯅꯥꯕꯗꯨ ꯐꯗꯣꯏꯅꯤ ꯀꯥꯏꯅ ꯑꯩꯅ ꯈꯨꯠꯀ ꯄꯥꯏꯕꯤꯗꯅ ꯑꯗꯨꯃꯥꯏꯅ ꯇꯧꯔꯛꯑꯀꯥꯟꯗ ꯑꯩꯁꯦ ꯑꯅꯥꯕꯒꯤ ꯁꯦꯕꯥꯁꯦ ꯅꯣꯡꯃꯥꯏꯖꯤꯡ ꯉꯥꯏꯕꯗ ꯑꯩꯁꯦ ꯈꯔ ꯋꯥꯕ ꯑꯃ ꯄꯣꯛꯑꯦ ꯀꯔꯤꯒꯤꯅꯣꯗ ꯅꯣꯡꯃꯥꯏꯖꯤꯡꯗ ꯗꯣꯛꯇꯔꯅ ꯑꯗꯨꯝ ꯂꯧꯕ ꯂꯥꯛꯈꯤ ꯑꯗꯨꯒ ꯑꯩ ꯑꯗꯨꯝ ꯊꯤꯟꯕꯤꯔꯝꯃꯤ ꯅꯨꯡꯗꯥꯡ ꯑꯣꯏꯔꯒꯁꯨ ꯑꯩꯒꯤ ꯌꯨꯝꯗꯁꯨ ꯑꯩꯅ ꯑꯗꯨꯝ ꯍꯥꯏꯖꯔꯦ ꯏꯆꯥꯁꯤꯡꯁꯤꯗ ꯑꯝꯇ ꯂꯩꯇꯦ ꯑꯗꯨ ꯑꯣꯏꯔꯒꯁꯨ ꯑꯩꯒꯤ ꯃꯤꯑꯣꯏꯕꯒꯤ ꯁꯦꯕꯥ ꯇꯧꯕ ꯆꯠꯂꯕꯅꯤ ꯊꯦꯡꯅ ꯂꯥꯛꯄꯗ ꯅꯣꯏ ꯄꯥꯈꯠꯀꯅꯨꯅꯆꯤꯡꯕ ꯗꯥꯛꯇꯔꯅ ꯂꯣꯏꯅ ꯀꯦꯌꯔ ꯇꯧꯕꯤ ꯑꯩꯉꯣꯟꯗ ꯑꯩꯅ ꯃꯣꯏꯁꯨ ꯍꯔꯥꯎꯔꯦ ꯑꯗꯒꯤ ꯑꯗꯨꯃꯥꯏꯅ ꯇꯧꯗꯅ ꯁꯟꯗꯦ ꯈꯨꯗꯤꯡꯒꯤ ꯑꯗꯨꯃꯥꯏꯅ ꯑꯗꯨꯝ ꯆꯠꯂꯛꯄꯁꯤꯅ ꯑꯅꯥꯕꯁꯤꯡꯁꯤ ꯌꯥꯝꯅ ꯅꯨꯡꯉꯥꯏꯇꯕ ꯑꯩꯅ ꯍꯥꯏꯖꯅꯤꯡꯕ ꯑꯃꯈꯛꯇ ꯂꯩ ꯑꯩꯅ 2017ꯗꯒꯤ ꯍꯥꯏꯕ ꯇꯥꯔꯦ 17ꯗꯒꯤ ꯆꯠꯄ ꯍꯧꯕꯁꯤꯅ ꯀꯣꯚꯤꯗꯀꯤ ꯀꯣꯔꯣꯅꯥꯒꯤ ꯈꯔ ꯂꯦꯞꯄꯨꯔꯦ ꯑꯗꯨꯒ ꯑꯃꯨꯛ ꯑꯗꯨꯒꯤ ꯃꯔꯛꯇꯨꯗ ꯆꯠꯄꯁꯤꯗ ꯑꯩꯈꯣꯏꯒꯤ ꯃꯅꯤꯄꯨꯔ ꯁꯣꯁꯥꯏꯇꯤꯁꯤꯗ ꯑꯩꯈꯣꯏꯒꯤ ꯐꯦꯃꯤꯂꯤꯒ ꯗꯣꯛꯇꯔꯁꯤꯡꯗꯨꯒ ꯇꯠꯇꯤꯡꯁꯤ ꯈꯔ ꯂꯣꯏꯅ ꯑꯌꯥꯝꯕ ꯂꯩ ꯍꯥꯏꯅꯗꯤ ꯂꯧꯖꯔꯒ ꯈꯔꯗꯤ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔꯁꯦ ꯄꯥꯝꯗ꯭ꯔꯤ ꯍꯥꯏꯖꯔꯤꯕ ꯄꯥꯝꯗ꯭ꯔꯤ ꯍꯥꯏꯕꯗꯤ ꯑꯩꯅ ꯆꯠꯂꯒ ꯑꯩꯒꯤ ꯔꯤꯂꯦꯇꯤꯚꯅꯤ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔ ꯁꯨꯃꯥꯏꯅ ꯔꯦꯖꯤꯁꯇ꯭ꯔꯦꯁꯟ ꯑꯃ ꯇꯧꯔꯀꯥꯟꯗ ꯑꯩꯈꯣꯏꯅ ꯑꯗꯨꯝ ꯂꯥꯌꯦꯡꯕ ꯂꯥꯛꯀꯅꯤ ꯄꯩꯁꯥꯁꯨ ꯂꯧꯔꯣꯏ ꯑꯗꯩ ꯅꯔꯁ ꯑꯗꯒꯤ ꯕ꯭ꯂꯗ ꯇꯦꯁ ꯇꯧꯒꯅꯤ ꯑꯗꯒꯤ BP ꯇꯦꯁ ꯇꯧꯒꯅꯤ ꯑꯗꯩ so many ꯇꯦꯁ ꯇꯧꯒꯅꯤꯅ ꯑꯗꯨꯃꯥꯏꯅ ꯀꯟꯚꯤꯟꯁ ꯇꯧꯔ ꯐꯥꯎꯕꯗꯅꯦ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔꯁꯦ now up till now hujik bed ridden oiraba ꯆꯠꯄꯁꯨ ꯉꯝꯗ꯭ꯔꯕ ꯃꯐꯝꯁꯤꯗ ꯑꯩꯁꯤ ꯊꯧꯕꯩꯃꯛꯀꯤ ꯃꯣꯏꯒꯤ ꯃꯔꯤ ꯃꯇꯥ ꯑꯩꯒꯤ ꯐ꯭ꯔꯦꯟ ꯁꯥꯔꯀꯜꯒ ꯍꯥꯏꯔꯨꯔꯤꯅꯦꯕ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔꯒ ꯋꯥꯔꯤ ꯀꯩꯒꯤꯅꯣꯗ ꯑꯅꯥꯕꯁꯤꯅ ꯀꯩꯅꯣ ꯇꯧꯔꯤꯁꯦ ꯋꯥꯔꯤ ꯁꯥꯕ ꯑꯃ ꯆꯪꯉꯤ ꯍꯥꯏꯕ ꯏꯃꯨꯡ ꯃꯅꯨꯡꯒ ꯋꯥꯔꯤ ꯁꯥꯕ ꯑꯗꯨꯒ ꯗꯣꯛꯇꯔ ꯅꯠꯇ꯭ꯔꯒ ꯗꯣꯛꯇꯔꯅꯗꯤ ꯋꯥꯔꯤ ꯁꯥꯕꯗꯤ ꯃꯣꯏꯗꯤ ꯃꯇꯧ ꯑꯃꯗ ꯗꯤꯁꯤꯄ꯭ꯂꯤꯟ ꯑꯃ ꯂꯩꯊꯣꯛꯈ꯭ꯔꯦꯕ ꯗꯣꯛꯇꯔ ꯂꯥꯛꯑꯒꯗꯤ ꯃꯣꯏꯁꯦ ꯈꯔ ꯌꯥꯝ ꯏꯀꯥꯏꯖꯕ ꯑꯃ ꯄꯣꯛꯄ ꯑꯃ ꯑꯩꯈꯣꯏ ꯑꯅꯥꯕꯁꯤꯡꯅ ꯐꯥꯎꯋꯦꯕ ꯑꯗꯨꯒꯤ ꯑꯅꯥꯕ ꯐꯥꯎꯔꯤꯕ ꯃꯣꯏꯗꯨꯗ ꯑꯩꯅ ꯋꯥꯔꯤ ꯁꯥꯕꯤꯕꯗꯣ ꯑꯗꯨ ꯑꯣꯏꯔꯝꯃꯦꯕ ꯑꯩꯒꯤ ꯃꯅꯤꯄꯨꯔꯤ ꯇꯝꯃꯛꯄꯒꯤ ꯑꯣꯖꯥ ꯑꯣꯏꯔꯛꯄꯒꯤ ꯁꯥꯔꯚꯤꯁꯁꯦ ꯁꯨꯃꯥꯏꯅ ꯇꯧꯅ ꯑꯩꯁꯦ ꯌꯥꯝ ꯅꯨꯡꯉꯥꯏꯅ ꯆꯠꯂꯦ ꯆꯠꯂꯀꯥꯟꯗ ꯑꯩꯁꯦ ꯕꯦꯡꯒ꯭ꯂꯣꯔꯗ ꯑꯃꯨꯛ ꯆꯠꯂꯀꯥꯟꯗ ꯑꯩ ꯗꯣꯛꯇꯔꯗ ꯍꯪꯖꯩꯌꯦꯕ ꯑꯩꯗꯤ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔ ꯆꯠꯇꯕ ꯉꯝꯃꯔꯣꯏ ꯕꯦꯡꯒ꯭ꯂꯣꯔꯒꯤ ꯀꯟꯇꯦꯛ ꯈꯔ ꯄꯤꯌꯨ ꯑꯩ ꯆꯠꯀꯦꯅ ꯑꯗꯨꯒꯗꯤ ꯖꯁ ꯃꯅꯤꯄꯨꯔꯒꯤ ꯁꯤꯒꯨꯝꯕ ꯈꯦꯟꯅꯕ ꯃꯌꯥꯝꯁꯦ ꯑꯃꯨꯛ ꯎꯔꯛꯑꯦꯕ ꯑꯩꯅ ꯑꯦꯡꯖꯥꯏꯇꯤ ꯂꯩꯔꯦꯕ ꯑꯩꯉꯣꯟꯗ ꯃꯔꯝꯗꯤ ꯕꯦꯡꯒ꯭ꯂꯣꯔꯒꯤꯗ ꯑꯩ ꯏꯆꯥꯅꯨꯄꯥ ꯑꯇꯣꯝꯕꯁꯤ ꯂꯩ ꯑꯗꯨꯗ ꯁꯦꯇꯜ ꯇꯧꯔꯒ ꯏꯕꯨꯡꯉꯣ ꯏꯃꯥꯗꯤ ꯄꯦꯂꯦꯇꯤꯚ ꯀꯦꯌꯔ ꯁꯟꯗꯦꯗ ꯆꯠꯇ꯭ꯔꯗꯤ ꯑꯩꯗꯤ ꯌꯥꯝ ꯍꯩꯅꯗ꯭ꯔꯦ ꯀꯃꯥꯏꯅ ꯇꯧꯏ ꯏꯃꯥ ꯆꯠꯂ ꯂꯣꯏꯔꯦ ꯀꯩꯅꯣ ꯁꯟꯗꯦꯗ ꯑꯩꯗꯤ ꯁꯨꯇꯤꯅꯦ ꯃꯥꯒ ꯑꯩꯒ ꯃꯥꯏ ꯒꯥꯔꯤꯗꯨ ꯄꯨꯔ ꯆꯠꯃꯤꯟꯅꯩ ꯑꯗꯨꯒ ꯃꯤꯒꯤ ꯂꯩꯔꯝꯃꯤꯕ ꯃꯌꯨꯝꯗꯨꯗꯤꯅꯦ ꯍꯦꯛꯇꯅꯦ ꯑꯦꯀꯔ 3ꯅꯦ ꯍꯦꯛꯇ ꯕꯤꯜꯗꯤꯡꯁꯤ ꯁꯥꯔꯒ ꯑꯅꯥꯕ ꯃꯌꯥꯝꯁꯦ ꯌꯨꯝꯗꯒꯤꯒ ꯅꯨꯡꯉꯥꯏꯇ꯭ꯔꯦ ꯃꯆꯥꯁꯤꯡꯅꯁꯨ ꯌꯥꯝ ꯂꯨꯅ ꯇꯧꯏ ꯑꯩꯈꯣꯏ ꯃꯥꯗꯣ ꯃꯃꯥꯟꯅꯕ ꯃꯌꯥꯝ ꯃꯅꯥꯛꯇ ꯂꯩꯅꯤꯡꯉꯦ ꯀꯥꯏꯅ ꯅꯨꯃꯤꯠ 6-4ꯅꯤꯒ ꯊꯝꯃꯝꯕ ꯃꯃꯥꯁꯦ ꯋꯤꯜ ꯆꯤꯌꯥꯔꯗꯒ ꯇꯧꯔ ꯃꯁꯝꯒꯗ ꯍꯥꯠꯇꯣꯛꯄꯤꯗꯅ ꯇꯧꯕ ꯑꯩꯈꯣꯏꯒꯤ ꯁꯤꯅ ꯑꯃꯨꯛ ꯃꯅꯤꯄꯨꯔꯒꯤ ꯑꯃꯨꯛ ꯀꯟꯇꯦꯛꯁꯇ ꯌꯦꯡꯖꯔꯨꯔꯒꯅ amu yumda hitana kaidodana bedridden oidana wana leiba mamana baga wari sawa kingaba chimu ai wona mu anxiety em lei adagi da ai di Mariana mari khatawi doctor na yang si angang nurse ni ai na ne beti ai nangi keno du da noi ngasidi keno ana ba seba to do ai bu puro aduga akoi jan pai mai da thambira mo ai chat ke hai mane ya re yang la pi anjin nang ya wani ai kwang se kra ko le ba su bu gi di pe kra le ma chi u ba da ma anjin nang dei si da koi kunga ma rom to ra ga akoi ana ba sun the le ra mi adu da adu mai to da na ai se moi de su ai le da ba kra jan pa na dan to bi ra mi mo ka le da no ka le da na ai na mu khale ai na lu ye na ai ma si bu ai akoi mani bu da mai ka le de phane akoi yum ju si da wa sa gi bi di le ye na hai ba bu ana bom le nong su le ke kai si bu ba gi ka to wa khan si da khale ye hai jen ba adu mai to da na adu na ai na mo hangi tan da ba ja kai number 1 ni nui lam ma su yam se akoi di parking le mo kai na tha ra ko na ga cha gi adu ga di parking ka ta si se le da na le ra me adai di ai goi si ka mai to no ma le ya kai na pin cha ni na cha da na ai han ana ma moi go me na li da to ra e ka ro si pi ra pa ni hai adu building yam sta cha na ana ba ka ta bi na te chu me pul la ma le le adai ki ka su e ta ne sa le beauty ka si thal la ga ana ba sing na chi ni than thal la ka da khoi gi imung di pit ra ba ka pu tu da na ri ni palliative ya la ni moi ngai da na ka su le ba khoi gi thang mai ba ya na yang kan ta ba noi na ka ni ne ai mo ra tha ra le ni ka na pham ma le ne den ma pham du da na ta freely ga mama na ba ga wari ga sana na mi sia ra ani ga dong ga thing jen na ra na ga to ai ma no di phang je ko moi do yang mai na le ba adu na khoi gi na ga ra ka na phang ba si da ai wa khan da nga tang ga ngau je ri ko adu mai to na ai na thok la ka na mo to ta da khoi gi mo du ji ro ra mo ai na tam ja ri akoi ji bu bo min de ga ni ru ba ya ga ai sa ke ne ai di thawa ing ha ga di ka ya ha je ba ka do ba ka di to ra tre mo ya bi dam ni na kwa kai ka cái nó tao ấy cái đấy là bây giờ bên này thế, anh ấy phải đi làm lu bên này na, anh ấy chúc mừng cái ori này thì sáng cái đi, chim này sao cả hai giờ rồi, phải hàng chim này sao cái đi, yang nak kasih xem cái lên này, ấy tầm jadi, anh ấy ngasih đi, sama sih na, ngasih cái palliative care cái sebab tu betul, anh ấy đi cái sunat cái đi, orang ini lejar apa ni, moi juga yang sana ya, yang mesti cái jomai thola cái jadi hangam bah lah dia mesti leram tu. Corona di matam du da ai si thar kuina tholo pa ya da na ai sai om US thola la de li da le thok re ba ai su operation nam chung ngai adu moi ani le ram da ba ai tu min la ka pi ba moi ani na lu na do ba si hanga ma ru cha ga pi America tha ga hanga ma ru asin ba ga lu in asu ki mati moi na kari gi noi na ha da ai che asa pot ku wei su na te kai mo sa moi ba ni su kai mo ai khang ya moi ba mi che moi gi wari sa ba mama sum ba che mai to ba ama di lei ba ma le hai da na ai na khan jai ai chal te gi si ka kan hai ja ga ai best kan tension ja ge thank you
madam na kamai na palliative care da yaw ba horokim no adagi wakalon kamai na khanbi ki horak pada na kari haina khanbiri tu mayam da thambira mutung da mayam ju wakhan khara khanda bini na khan soidana maki khanda gani na khanjai thank you ma'am mathang da next I would like to put question to our representatives from the different volunteer NGOs or organizations. First, I would like to put the question to one of the organization's representative, Dr. Ngangum Arun Kumar Singh. He is a representative of the organization called Manipur Adventure and Mountain Biking Association. They have been involved in activities of the Palliative Care Society Imphal in some way or the other. I would just like to ask Sir Arun, what other activities you have been doing as organization, and what is your vision or what you think you can do regarding these palliative care services through your organization?
Thank you, Dr. Gautam. I, as a representative of a cycling association, just want to share a few thoughts how we could be a part of this palliative care volunteering service. We have in the past coordinated with the Palliative Care Society in Imphal, and we have awareness campaign through cycling rally. We know that this palliative care voluntary service could be a very good choice now, but there are certain limitations that we need to know. Such a palliative care service is available. This is not aware among the public. So number one hindrance in this volunteering service is awareness. Many are not aware that such a service do exist. And for those few who know that such a palliative care service do exist, they are not fully aware what type of services do they provide. And we as a public, what role do we have to play, can we play in such volunteering service? So my suggestion is that it is very important to identify the role of a volunteer, a non-medical volunteer, or a general public, what role they can have in such a palliative care service. And for this, I would like to suggest that there should be a proper certified training program, so that such volunteer can be involved. And such a certificate program should be beneficial to those volunteers, because most of them they are young, they are students, and this could be a criteria for their placement, for getting a job. Like this should be one thing that we can consider. Then role identification. So we can identify their role, what they can do. That is number 3. Then number 4 is that time allocation. Like there should be proper allocation of time, and this allocation of time should be at the convenience of the volunteer. Like how many hours per week or per month they can allot. This should be flexible. So these are some of the suggestions that I want to suggest. And one last suggestion is that if they are ready to volunteer, and if they are giving volunteer service, this should be certified, and this should be beneficial for them for getting placement in private sector or in government sector jobs. Thank you.
We accept your suggestion, we have noted, and further I would like to ask you, sir, whether your organization will be available when we approach. What are the limitations from your side?
Like we have been organizing such awareness program, not only palliative care, for many other organizations also we have been organizing. This is not an issue. We can do the awareness campaign, but with regard to the volunteering service, that can be considered. Cycling is a very acceptable mode of convenience, healthy, eco-friendly. This could be a mode of convenience for the volunteers to access to the terminal patient who are in very small road, nook and corner of the small town, village. So we can be like a way to deliver this volunteer service. This can be considered. Thank you.
Thank you, sir. Next, I would like to come to the representative of Indian Red Cross Society, Imphal West, Sir Dr. Koizam Arunkanta Singh. Sir is the chairman of Indian Red Cross Society, Imphal West, and sir was earlier medical officer of the Imphal Municipal Corporation, now Corporation, Imphal Municipal Council. Sir is a retired person now, but he has been actively involved in many activities. Sir's organization also has been associating with PCSI in some of the activities. So first I would like to ask Sir Arun Kanta, through the Indian Red Cross Society Forum, are there any other activities related with healthcare services, and how you would be able to link with these palliative care services?
Thank you very much, Dr. Gautam. I, as a chairman of Indian Red Cross Society Imphal West District Branch and Vice Chairman of the Manipur State Branch. See, our organization is working under the 7 principles. So, and we have been doing all the programs of, say, first aid training and disaster response and distributions of, say, any fire victims and then flood, etc. And even we are giving a first aid awareness to the community level and to the students and even the training also. So we are having a lot of volunteers, which are very active volunteers. So in this regard, and we have been associating with this PSI. So Indian Red Cross Society Manipur State Branch is having 9 branches in 9 districts. So we have got, say, like Sandel, Ukhrul, Sanapati, then Chosampur, and then Tamenglong, Imphal East, Imphal West, and then Bisempo and Thawal. So in this area, we can we can do the awareness program. We can take off, or to find out where are these patients in that locality area, and so then we can make a. If my suggestion is that if these associations have these branches along in this area, then we can tie up with all those local clubs and CSOs or MyRPIVs, community leaders. Then we can give awareness to them, make them understand what is palliative care. Then only if those things are increases in mass, then if people comes to know that what is palliative care, then I think it will be more benefit, and we can expand in other parts of the interior part of the Manipur. And even then, if not, we start in all the districts, or we can select some districts where we can, as a first phase, we can start taking volunteers. And then all these volunteers, if this BSI have got these branches, then we can have the members and volunteers. If these are, we have got all these people, then we can join it together, we can work together. So even then, so like that we can approach in other NGOs also to come and join with us. And we are giving training among us, among the volunteers, then we can make them go to the field and identify the areas of that locality, and then they can take, as a, say, like you are having the directory of guide and all those, see, in that area how many doctors, nurses and all those, then we know that then we can be the guide for that in a director. When they are need, we can ring to the doctors or nurses and all. As these are the main palliative health care what I've gone through and listening at today's topic also. Then this is the most of the medical professionals or paramedics care. So then non-paramedics or non-professionals, health professionals, like these, like NCC or like our cycle associations, and then this in the Indian Red Cross Society or IMA, or all those we can take up in the full in the awareness program. This is more important to make the people understand what is palliative care. And so in this, any organization or something, we need financial support. Without the financial support, if you go to interior parts, then we need some fund for that. So we should go for the membership drive. Then only, say, we can have some fund for organizing such thing. So these are the things, and even the Indian Red Cross Society will try to talk to the national headquarters. What can we go in this palliative care society? In what way we can take part and help? That I'll talk to our national headquarters in a very short time. Thank you very much.
Thank you, sir. Regarding one of your these suggestions regarding to incentivize the volunteers, I think what we learned from Sir Suresh states Kerala model, volunteers are not incentivized, they are not paid. Volunteers are volunteers, they have to come forward and serve. So what we want is to volunteer themselves and to get themselves involved in this delivery of this palliative care services. I think yes, for states like Manipur, because of this difficult terrain and yes, far-flung areas, I think we can discuss and think over the modalities in what way we can encourage these volunteers more, if not financially also, means how to incentivize them. Okay, so that point is also noted. And next, I would like to come to the representative of Doctors on Pedals, the cycling wing of Indian Medical Association Manipur State Center. So Dr. A. Vivekananda Singh, please sir, put some light on the roles which Doctors on Pedals can play in the delivery of palliative care services.
Yeah, thank you, Dr. Gautam. Good morning to all, to the panelists and the audience. I am here as a representative of Indian Medical Association Manipur State Branch, and Doctor on Pedals is it's a wing of Indian Medical Association Manipur, whereby some enthusiastic doctors have joined hands to form a wing, and we do regular cyclings, and then once in a while we carry forward some social messages to destinations that we go. As I was waiting for this panel discussion, one nice line I just came across while waiting. I'll just, for the benefit of, nothing lasts forever. Your beauty, your wealth, your fame and authority, even your sweet relationship, but your righteousness and your good deed will be remembered by all for many years. So it just coincides with the theme of voluntarism. So I thought I should start my few words with these lines. Indian Medical Association is the largest group of doctors, and in fact all the key personalities of the Manipur Palliative Society, they are all members of IMA, and being in the medical field, like we are the right NGO to take forward the thoughts of palliative care to the society, even to our other colleagues who are not so aware of this particular theme. In fact, Manipur IMA has already given a letter to our headquarters in Delhi, whereby IMA national headquarters is being requested to take up palliative care as a core subject to be initiated in all the IMAs of all the IMA branches and the local branches of the whole country. And in fact, they have already acknowledged it. And then at the local level, as I have already told you, many of our palliative care key persons are in the IMA. So we are at the local level also taking forward the message. we are in tie with the state health department also. Now the question of these volunteers. So what IMA can do is like to ignite the sense of volunteerism. One external stimulus is required. There will be many people who want to volunteer, but they may not be knowing the right place or the right time to lend out their services. So that external stimulus can be ignited by the esteemed IMA members by giving this thought of palliative care by spreading the awareness at your workplace, or maybe we can arrange awareness camps by visiting various villages or other distant places. And then, as Dr. Arun has already said, like cycling can be one of the mode of this thing to reach out to those villages or those distant places. My personal experience, like being from a medical background, in my family circle, I had the fortune or the misfortune. Like I am fortunate enough to look after many of my relatives at their end stage, starting from my maternal grandmother, who died of CA carcinoma, pancreas, when I was a medical student. My grandfather, my grandmother, my grandmother's sister, everyone, like, so I have a deep sense of this thing, like that end stage experience of giving medical care to those end stage patients, whether it's due to old age or due to any terminal disease. So we as an association of doctors, like, we are already in this field, so we should take this thing forward as an association. And in this field, we already have taken our step. We had some discussion in the Dr. Suresh camp last time also. One TED cafe discussion, which was very like eye-opener for every one of us. So with these few words, I think we can continue with the discussion. Thank you.
Thank you, sir. Your points well taken. Next, I would like to put a question to Sir Dr. K.S. Manglem Singh, past region chairperson, Lions Clubs, International District 322D. Sir is also the president of Palliative Care Society Imphal and organizing chairperson of this 4th Pallicon 2023. The question I would like to ask, sir, is what roles a volunteer can play in the delivery of these palliative care services? What are the different roles which these volunteers can play? So please put some light on it.
Thank you, Dr. Gautam. A bit of a short history of Lions Clubs. This is the largest non-profit organization in the world, established in the year 1917. Lions Club of Imphal was established in 1968. After that, there are more than 30 Lions Clubs in Manipur at present. So from the beginning, we have been doing as a norm humanitarian services in many ways, including health, education, environment, many other things. And our main focus is in the prevention of blindness, sight first. Sight first is our still priority. Just like Rotarians' first priority is poliomyelitis elimination. Then, at present, we are focusing on the diabetes, awareness, detection, then childhood cancer. Mainly we are focusing on these lines. And of course, palliative care is new to us. Probably it may not be very much popular in the international forum also. And in due course it will be included in our activities. And we are being dictated from the Lions clubs, multiple international like that. So we usually do one activity like that. So last year in the month of November, we did diabetes month. We organized diabetes month. We did many screening cases. Likewise, we may be turning our attention to palliative care also, because we are all ourselves are volunteers, because we believe in service. Our motto is we serve. So definitely we can reach to the people, and we get some, after getting some sensitization on this subject, and moreover we can adopt some of the patients requiring palliative care in our localities. We have got different Lions clubs in different areas of the state also. So this in our part, we contribute ourselves for the humanitarian service. Sometimes we do fundraising, not very common thing. So we contribute, we give many things. We help, we cooperate, we conduct health camps, we feed the needy. So this is not a new thing to Lions clubs. We can do it about proper sensitization. We have to make them aware, because such thing is there, and we'll turn our head on that. That's all. We are volunteers. No financial involvement. We will contribute ourselves. We have been doing that. Thank you.
Thank you, sir. Next, I would like to come to Sir Retired Pramod Kumar Chavra, past President Rotary Club of Imphal Rotary International District, 3240. So, the question is, what role your volunteers or as an organization you can play in this delivering palliative care services? Same as asked to Sir Manglem, what your organization can do as a volunteer, or you must be having some this volunteer platform. Not only the members, only some these local volunteers engagement might be there, and these youth students, you might be having lots of all those people also. So in the real delivery of palliative care services to the people, what your organization can do? That's the question for you.
See, the motto of Rotary International, as I say, we are just a part of that. We are a small unit named as Rotary Club Imphal, and our motto is service above self. The first motto, and the second motto is that service to the humanity is the rent we paid for our stay in the universe. So we follow these two mottos, and by these two mottos we have members who are ready to volunteer for any type of humanitarian services. Then as you ask me, what is the level we have in schools and high schools and colleges and university level and at the local community level, I'd just like to inform you our organization structure. We have the main club, that is Rotary Club. Then the sub-junior is known as Rotary Club, where we engage the students or say the young youths, both male and female, from the age of 18 to 35, or 35 is the maximum, where we engage them and we train them for services. So localized we can do that way. Then we have in college level, and school level, that is from class 9 level to up to class degree level. We have interstate, we have interact clubs, that is known as those boys and girls who have some enthusiasm for service to the humankind. We take them as our members and train them as members to do some voluntary services for the humanity. Not only the humanity, we do services for the earth also. So we can plan in that way, and as Sir Mangalagan has just told, Lions Club and Rotary Clubs both are the service club oriented clubs. We have, say, right now we have some 180 members in Imphal, in and around Imphal. So we can just give you some financial help also when, and it's not every time that we will give you a financial help, but we can go, as I say, elderly people of the society, we can go to a patient and serve them. We can give them some consoling words, and as Dr. Lenin was telling that, we can give some spiritual services also. Spiritual services are required. This is, I am a Jain, and we have a line that we command ourselves, Jahan tak ho sake main auron ka upkar karu, means whatever is possible or where, which extent it is possible, I should serve the humanity. So these are the 2-3 words which, and I think not only Jains, in everywhere, in every community and every religion, service to the mankind is the supreme religion. So we can follow those religions, and Rotary Club here in Imphal, I'll just like to say that Sir Mangalagan is being Lion Club member, he is the person, and the vice person is a Rotarian again. Dr. Jumindra is a Rotarian, Dr. Pallicon is a Rotarian. So these 2 clubs are doing services for everything. So we are always ready, and we are looking after it. See, this is, I think this is my 4th Pallicon which I am attending as a panelist. So Rotarians are there. One of our very active Rotarian Lender Thodam is lending his vehicle every Sunday. Like that we are doing voluntary services, and for volunteers, as Dr. Suresh has just told, that we don't require any incentives. We are ready to pay from our pockets also. Thank you.
Thank you so much, sir. Now we have learned from the representatives of the different organizations that all of them have been doing some humanitarian service in one way or the other, though they are not directly involved with the real palliative care services. And we are glad to hear that they are ready to get themselves involved also. And since yesterday morning we have been discussing about what is palliative care, palliative care, till now I think most of the audience, our students also, they might have learned that palliative care is not only about the care for the patients, it's about the care for the caregivers also. And when we talk about patients, it's not about the underlying disease, it's about the emotional aspect and the spiritual aspect, those support mechanisms also, and support to the caregivers, and even after that the bereavement process. So all those things are involved. So to put more light on this matter as an expert, I would like to ask Sir Suresh Kumar to elaborate on how these volunteers can give support or services. So all the possible roles of a volunteer, please put some light on this.
I would suggest that, because we have been looking at volunteers as a separate body, another way of look at it is, actually I would suggest that we look at individualization. For example, look at a patient, for example a patient in the community, who is involved in the care. Like the immediate family members are involved, and the line between the family carer or the carer and the volunteer after a while becomes a little bit blurred. Because, for example, the patient's son is involved, looking after, we take it as natural. Son's friend comes in and helps. So where do you place that friend? Is he a volunteer or is he a part of the caring system? The patient's old classmate's son comes. The local politician comes and helps. or the social worker in the area. So one way to approach it is, like ideally, actually that's the real solution. You look at the patient and look at who are around the patient, who else would like to get involved, and what role can they play. Look at the need, because you cannot, the same package cannot be offered to all the patients. Each individual patient, the needs are different. Somebody may want somebody to sit with that person in the evening. Somebody may want a person to go and fetch the children from school. So the one way, practical way of approaching would be, look at the patient, look at what are the needs, and look at who are all involved, who else can be involved. So there you can, if there is a gap, you can fill in with your conventional volunteer. So otherwise, if you ask the volunteer, you are not creating a specialist group in the community. You are empowering some of the people who are willing to help. So I think that should be the better way of looking at it, rather than having a volunteer to break bad news, having another volunteer to offer support. No, that may not be possible and that may not work also. The best option would be to focus on the patient, look at the needs, who is fulfilling, where are the gaps, who else can be. So that can be from the patient circle itself. And this person may be like, if you network with each other, link them with each other, these people will be able to help with some of the other patients also. So that may be one better practical approach than, the two we need to work on both. Having a pool of volunteers as buffer and also looking at that's what I feel.
Thank you so much, sir. We are running out of time also, and as a last common question, I would like to just open to all the panelists, except Sir Suresh Kumar, one suggestion each from all the representatives here, so that we can do this, we can give these palliative care services very nicely, and at the grassroots level also, and how we can build up this volunteer base and how we can function nicely. Ma'am Sarojini gi yam tentak na thambiro ma'am haidi akoi si role of volunteers habam lere the volunteer base kamaina sagat kani si yam tentak na suggestion amatang thambiro.
Sagatpasi ay koksi sakar manungsida layraga khalle anaba chiba toba adagi anaba gi loinaba akoi manipur sida foundation di yam lingna leiba aduga sari hetare miyam dagi response ay personnel tawjabani ko mafam unda chalaga meeting tawbadagi moi singse loinaba interest leiba dona tawi adu ID individual da aina leiba yum si da bisangi chhatra oiro parents yam pulle ba ko gesida adu aina hamba da moi ta bo taram da ba adagi kaino palliative care bo kai na haiba
adu madam na marakta chaki madam na hai biji ningi se moi se awareness level wale have ne ba awareness level wale adu akoina awareness khare hena toragadi
ada tau basigi maram se aina mase syllabus ta matang di
syllabus ta
syllabus ta matang di hapan ninge maram di syllabus ta atraga di aina akoi dia da hang baju ngarang ma hange aina moi pe
thank you ma'am ki point to akoina hujik sim note tawjare adu ngarang ki panel discussion amada akoi ki professor Progen Singh akoijan din RIMS na adu ki ngasai gi curriculum da kaino da hapna bagi angang singi like tam da yauna bagi process to haurani na haidi din mayam kauraga aduga kaino medical college mari gi oina hauba na araina mana paikhalani na takpi ji ngara adu madam gi point to soina maki paikhala ka do mali numit matam khara gi manumta
adagi amana ai amakataga amta hanga chage hoyi kaino sesida kani ai hudi amu haige torata ka phopam story ai kaino se awareness kitang toy na haipatari akoi loina baksi matam chinna banga tan thaina chin bade hidinga mohen chin gre aduna chin la su chin na masi akoi gi manipur da di kitang Pugaina Sanambase, Tanquina Sangani Hajeriba. Another syllabus say our awareness program say, Lam Long Puddingi, Club Kumbanga, Samnaraga, Aquita Urenahan, Aina, Kariba, Oriental College, Maningi, Juda Mapun Juda, Hakiraptana, I said, the joint of Yarureva. Kudak to the dinner, which is already at the Tulake, at the Toke Haiba. Practical way, the monkey,
Thank you, ma'am. Madam ki point ma'am note ho jare koi awareness su boost up tauna ba activity hingat ba hona jare. Next, Sir Chabra, please. Any suggestion? Only one suggestion, which you think is most
I'll
important.
just give 2 words: awareness and information. That's it.
Sir Arun Kumar, suggestion of the Thambil. Same. So,
like St. John's and Red Cross Society to have this ongoing certified training course. There should be such palliative care service course, and this can be outsourced to third party like IMA. If palliative care is very busy in delivering these palliative care services, they can be outsourced to NGO like IMA, and this could be an ongoing certified course and done free of cost.
Okay, thank you, sir. Your point noted. Any other suggestion from the representatives?
Dr. Gautam, last one is everybody is giving this thing. Number one is awareness. So, like in colleges and schools, International Red Cross Society is having the Youth Red Cross and then Junior Red Cross in school level. In this area, if we impart the awareness what is palliative care, I think it will be more valuable for this research. And then even the NCC, International Red Cross Society, we are imparting awareness and giving training and first aid to the NCC groups. So every year they have got up to the college level having these games. So there we impart all this awareness and training. So like that, as our Dr. Arun said, there should be training for this. Say like Red Cross and John Ambulance, all those. We already have our volunteers. If we impart more about this palliative, about the care, and then even they can go from village to village from any interior part for this awareness program. Thank you very much.
Thank you so much, sir.
Besides these IEC activities, what we can do is we can identify general public or citizens who had some sort of first-hand account or experience with terminally ill patients, maybe in their family circles or in their locality or something like that, and they can also be like motivated to become volunteers. Thank you.
Thank you, Sir Vivekananda. And your all points are well noted, and now we agree that just I would like to summarize the panel discussion that all of us agree that there is a very large gap in the IEC activities. Awareness level is very low, so we need to do lots of activities regarding that, and yes, we can collaborate with so many other organizations, and they are all ready to involve in the palliative care service delivery also. And with note that we will be trying our best to collaborate with other stakeholders and try to motivate the general public also to get involved, and we look forward for this opening more branches in different districts also. And I believe the palliative care services in Manipur has a very bright future. And last of all, I thank all the panelists for today's panel discussion, for sparing their valuable time and joining this event. And with a note of thanks from the Palliative Care Society Imphal side, as a Joint Secretary of Palliative Care Society, Imphal, and for this conference, as a convener of the scientific committee, I would like to thank you all once again, and let's hope for the best. Okay, thank you all. Oh, I would like to request all the panelists to please be on front side of these tables and let's have a group photograph. I request Sir Jugindra and our secretary Sir Zuhoda also to join.
Thank you, Dr. Soram Gautam and all the panelists for the wonderful session. I would now like to request Dr. K.H. Poni, CEO Shija Hospital, to kindly come on the stage and felicitate all the panelists. Thank you, ma'am. I would like to request Professor H. Sanaima Devi, Professor Community Medicine Department, RIMS, to kindly felicitate Dr. Soram Gautam for being the moderator of this panel discussion. Thank you all the panelists for joining this panel discussion.
Thank you, ma'am, and sir.
That was very enlightening panel discussion on role of volunteers in in palliative care. Thank you all the panelists and the moderator for making it an interactive session and sharing your experiences. Next, we will move on to the most awaited session, that is the award distribution for the paper presentation which was held yesterday as the first session of Pallicon 2023. For conducting this award session, I would like to invite Dr. Soram Gautam on stage.
Thank you, Dr. Avantika. To give away the award for the best paper presentations, I request Sir Suresh Kumar again to please come on the stage. Sir Suresh Kumar is the chairperson of Scientific Committee. These paper presentations we had judged according to some criteria. First, originality and significance of the study, the materials and methods, the clarity and logical flow of the presentation, the oral delivery, audience impact and timing, and the visual quality of the slides and the answers given to the questions raised. So, after judging the presentations based on these criteria, first I would like to announce the third prize. So, the third prize goes to Dr. Anastasia Sangma, Department of Community Medicine, RIMS, PGT. The title of the topic the title of the study was Perceived Needs and Challenges of Non-State Caregivers in Palliative Care in Imphal West District, Manipur, a qualitative study. The second prize goes to Dr. Ankit Chandra, Department of Community Medicine, AIMS, estimating the need for palliative care in rural Haryana, North India. And the most awaited, the first prize goes to Dr. Isaac Lalrong Baula, PGT Department of Community Medicine, RIMS. The topic of the study was Experience of Healthcare Workers and Caregivers under the Palliative Care Program in Bishnupur District, Manipur, a qualitative study. Thank you, sir. And the rest of the participants, the oral paper presentations as well as the poster presentation, they can take the certificate from the registration counter. Thank you.
Thank you, sir. And once more, congratulations all the award winners. Now moving on to the last session for this Pallicon 2023. This session is on palliative care for elderly and caregiver burnout. Now I would kindly request Dr. K.H. Boni, CEO, Shija Hospitals and Research Institute, and Dr. Kennedy Tayanjam, Consultant Anesthesiologist, Shija Hospital and Research Institute, and Dr. D. Pibaral Mete, Managing Director, Midilane, to come on to the dais and to chair the session.
I would like to request the chairpersons to take over the session. Thank you.
Yeah, hello. Very good afternoon to everybody. After having had many sessions on different aspects and the different spheres of palliative care, we now come to one of the very important aspect, that is end of life care. That is about how we can render services at the last few hours or few days of the end of life, not only for the patient but even for the family members and the near and dear ones for the patients. So for that we have our esteemed speaker, Dr. Punit Rathore, who is the head of the community medicine. Where is that? So there is the Gangaram Hospital. So we welcome him and please speak on that. Thank you for that.
Very good afternoon to all of you. Thank you so much for your kind words of introduction. So as we come to the end of this beautiful conference, the topic for today will be end of life care. So why is end of life care very important? What is the role of the doctors, the nurses, or for that matter everyone while dealing patients who require end of life? So end of life and palliative care aims to help you if you have a life limiting or life threatening illness. The focus of this type of care is managing symptoms and providing comfort and assistance. This includes help with emotional and mental, spiritual and social needs. End of life and palliative care provides practical help with daily tasks also. The goal is not only to improve your quality of life but also to improve your quality of death. End of life and palliative care is based on what your needs are. So why do we require a good end of life? If we see in the ancient times, our life span was just around 40, 50 and then it kept on rising. In initial days, infection would come, pandemic would come, people would die, the lifespan was less. But what about in the modern age? Due to the advancement of science and technology, medicine, and various therapies, for example, newer immunotherapies, newer chemotherapies, modern technologies, the lifespan has increased. You can see that at present in India, it's nearly 70 for both, on an average, for both male and females. So, what happens? More the lifespan, more the complex diseases. We all know, as we were talking yesterday, more communicable diseases are there. People now, they suffer from diabetes. People now, they suffer from hypertension. They have all these kind of new communicable disease, communicable diseases, which leads to a bad end, right? They have a lot of morbidity. They face a lot of difficulty. They have they are on multiple medications when they advance as the life progresses. So we all know what is the outcome. The real outcome is death. But what type of death? Is it a good death or a bad death? So that will be coming to that slide later. So this slide is very important, and I want each and every one of you to read this, think, and if any one of you can answer, please answer. If given a chance to plan last few months or days of your life, where how and with whom would you like to spend that time? Anyone can just speak from your respective seats. At the last time, what type of death do we want? We all, like if you tell me, I just want to sleep and go, right, without any pain. I guess everyone wants this type of end, right? Most of us want to die at home, in front of their near and dear ones, where their last wishes are fulfilled. They have time to say goodbye to each and everyone, where their unmet needs are fulfilled, right? But what is the scenario? Do everyone get this type of end? No, right? Someone told? What type of death do we get? Or normally we get? Right? We land up here, alone, with multiple tubes. When we know that the treatment is futile, we all land up here. Basically, if I tell you, the world is full of agony. The poor, they die in agony that I wish I had some money to take my patient to the hospital. The middle class people, they say, I wish I had more money so that I could put my relative or my patient in the ICU for extra care. And the rich people, they die in agony. They keep the patient in the ICU. They say, I have a lot of money. But in spite of knowing that the treatment is futile, there is nothing left. Still, go aggressive. Keep the patient on ventilator. So, do we want this scenario or do we want the previous scenario? I can't hear. Okay. So all of us deserve a dignified end, right? So what do you mean by a dignified end? It means a good death. So to tell you what is good death is one that is not bad in simple terms, right? It is free from avoidable distress and suffering for patients, families and caregivers, in general accord with patients and families' wishes and reasonably consistent with clinical, cultural and ethical standards. And what are the principles of good death? To know when the death is coming and to understand what can be expected. To be able to retain control of what happens. The patient should have that control that, yes, when I am dying, this is what I need. This sort of aggressiveness I require. I want this person to be with me. If the person is staying in cities, he says, no, I want my last breath in my hometown. Or for that matter, I need to visit this place before I die. So these things should be taken care of. To have access to any spiritual or emotional support, to be able to issue advanced directive planning and to have time to say goodbye. Just a second. Nandan, slide. I'm so sorry, some technical glitches. I'm so sorry. Yeah. So, while providing a good death, so what are the steps we require? So, generally we follow the 6 step of end of life care approach. First is to identify when to initiate, whom to initiate. Well, we have so many prognostic tools, for example, palliative prognostic index coming up. So we can we can have a rough idea of the prognosis of these patients. We have another goal framework guidelines. So here we can know that yes, the prognosis is less than a few months or days. So yes, these are the patients who can be counseled for a good death or for a good end of life, right? So in simple terms, if anyone asks me, like, how will you know? So suppose a patient comes to you and he's deteriorating in days. So we can say that yes, he has days left with him. If he's deteriorating in weeks, we can say he has few weeks left. And if he is deteriorating in just few hours, we can say yes, he has few hours left. So this is how you need to approach. Based on this prognosis, we need to take care of the respective needs. All the needs are individualized. You cannot give same treatment to everyone. It should be based upon the individuals. Second step is assess. That is assessment of physical symptoms and distress. See what all symptoms is he having. Is he having pain? Is he having breathlessness? Is he having hemorrhage? Is he having spiritual distress? Is he having psychological distress? Is the patient very anxious that time? So all this need to be assessed. Non-physical issues, like in the just before our session, we had a very good talk on spiritual needs, right? So generally we have seen that when the disease is diagnosed, the patient has some psychological issues, for example anxiety, and he has some coping issues. But as the disease progresses, later part of the time, he tries to find meaning. He tries to find purpose. Why was he here? He has these spiritual issues. Why am I here? What did I do so that I deserve this? Right? As Sir mentioned, that we should listen to these distress, and we should try to make the patient comfortable. We are not here to make them feel more guilty. We should choose our words very correctly. And third step is planning. Plan what? The site of care. Where do we want? The hospital or some respite center or the home. Review existing care protocol or medication chart and stop all unnecessary intervention, medications and investigation. And anticipatory prescription writing. In the morning we had a question to our esteemed faculty, right? Like, what will we do when we have end stage patients who bleed, right? Whose Foley catheter gets bursted out. So palliative emergencies won't remain emergency if we counsel the patient and relatives right from the start. If we know that the patient has a mass in the neck and we know that carotid blowout can be there in future, it is our duty to tell them that this may happen. And is it just that this may happen? No. We should tell them the solution too. Tell them about the medications. Tell them about the dark clothes which we need to apply, because that is very important. The patient won't be anxious. The patient is there, he's anxious. Apart from that, his relatives are more anxious. They can't see the blood coming out. So we need to tell the non-pharmacological aspects, explain them that yes, these towels are to be used. This medication can be given for local application, and if the patient is taken orally, we can give that. If the patient has severe pain and can't take orally, subcutaneous option can come into the picture. So these plan has to be taken care of. And how will this plan be effective? It will only be effective by three things. First is communication, second is communication, and third is communication. True communication. Now coming to the fourth step, that is provide access to essential medication for end-of-life care symptom control. That is very important. I'll be coming in the subsequent slide that what are the common symptoms. Dedicated space and round-the-clock staff. Yes, sometimes if the patient is in periphery, we won't have a round-the-clock staff. but we can always have a licensed telephone number so that that can be given to some palliative care physicians or palliative care nurses or some volunteers, so that they can take that call and provide that support at that time during emergency. And after that, care and bereavement support is also very important. And step 5 is reassess, ensure adequate control of pain and other symptoms through ongoing assessment, document any variance and initiate prompt action. The last step is reflect, review the care process and identify if there were any gaps. This is the most important part. Reflect, keep on reflecting what you have done, because as I had told in the beginning, one plan, it's not sufficient for everyone. It depends upon the priorities of that patient, depends upon the needs, depends upon the prognosis, depends what the patient wants. Basically, it depends upon the goals of care, what we want to deliver. So end of life care decision making is, yeah, I know it's hard, but yes, while delivering, all the primary physician, palliative physician, the nurses, the volunteers, all have to come to a platform, the common platform, that yes, now this patient is assigned, is termed as end of life care, and we need to approach in a different, in a compassionate manner. Communication regarding what? Honest, it should be honest and empathetic, it should not be sympathy. Step into the shoes and feel. It should be empathetic rather than just showing some pettiness or sympathy. And while communicating, family and caregivers are informed, educated and supported about prognosis. A preferred place of care and death should be identified. Caregivers are involved and empowered to provide end-of-life care. This is very important, because if the patient is at home, if we teach him, if they are empowered, they know, yes, if this situation arises, I'll give this. If severe pain is there, I know that yes, the PRN dose is this and it can be given. If the patient is having severe breathlessness, yes, I can do this. So this education and empowerment of caregivers is very important. And you can't really give this knowledge to all the caregivers, but yes, whenever a patient is there, identify 1 or 2 close relatives who are there taking care of that patient and try to teach them. And continuity of care should always be there. Discuss about after death protocol, it's also important. So what are the common symptoms in end of life care? Pain, it's one of the most common symptom. And how will we manage this symptom? Based on the WHO criteria, yes, if it is mild, you can give it weaker drugs. If it is moderate, yes, weaker opioids can be started. If it is severe, severe opioids can be started. Restlessness and delirium is one of the most common causes, and it is commonly seen in end-of-life care, right? So what can be done? Environment-friendly place should be established. The patient should be in the house or wherever he wants to be. He should be in front of his relatives, and if possible, yes, if a window is attached, try to take him near the window so that orientation is there. And if pharmacological methods are required, we can go ahead, we can give a low dose of haloperidol as well. Respiratory secretions, again very important, because at the last time, this respiratory secretion or grunts, we call gasping, those noises, heavy noises are felt, right? The patient, he is in a comatose state, he can't really feel, but the caregivers, they are more distressed. My patient is suffering, some noise is coming, what to do, what not to do. So this is the time to explain them that this happens in this stage. Reassure every time, communicate properly, and if at all secretions are very much, yes, bit of suctioning can be done, not much, and anticholinergic medications can be given. Similarly, for breathlessness, again, non-pharmacological methods are very good. A fan can be put near the face of the patient so that the trigeminal nerve gets stimulated and the perception of breathing gets decreased. As I told you yesterday, the role of opioid is very good in managing refractory breathlessness in these patients. Go with small doses, 2.5 milligram, and keep on titrating according to their needs. So these are the common symptoms, for example, constipation, loss of appetite, incontinence, these are others. So you need to manage these as well. And apart from these, there are psychological, yes, anxiety, depression, these are very common. Grief will be very common in when the patient goes, and bereavement process should also be good in this stage. The culture, we should, while giving end of life care, always remember the cultural aspect should always be taken care of. It's not like, suppose a patient is Hindu and he's dying and we ask the priest to come and do something. See, at this time, it is like, and yes, religious thing and cultural thing should be in accord with the patient's preference, right? If he wants that, yes, I need a Ganga jal in my mouth, yes, put that. If they say that, yes, I want to pray bedside, yes, please do that. If the patient is a Christian, he wants a priest to be there to say the last, to pray for the last time, yes, please encourage that. So these small things should be encouraged, and this spiritual aspect should be dealt in a very gradual manner, not like very aggressive, or it should not hurt the sentiments of the patients. And once the patient passes, the after-death care should also be very good. Culturally appropriate and sensitive after-death care. Information about the death should be communicated. The primary team should be informed. The palliative team should be informed. Everyone should at least come and talk to the caregivers once. The body laid out in culturally appropriate manner. Provide presence and support to the family. Privacy and space to the family. Timely and correction, verification and certification of certificates. That is very, very important. We have seen in government colleges that the patient dies and the body is handed over only after 5-6 hours. Certification, there is some mistake. So these things we should keep in mind that they should be early and as early as possible and with culturally appropriate manner. And a good bereavement practice should also be given. So to conclude, a good end of life care is a human right. It is for all. We all deserve that. To achieve a good death for any person who is dying, irrespective of situation, place or diagnosis of illness, and the emphasis in our end of life care should not only be on good quality of life, but it should always be to provide a good and a dignified and a good quality of death. Thank you.
Thank you, Dr. Punit. The stark realities that you presented in front of all of us has put at least me dumbfounded. The reality of a human being born and the certainty of the death coming to each of one of us. We have been made again aware of what situations at the end of life is going to be for everyone. The palliative care, now that it has emerged since now more than a few decades, at Imphal, this palliative care unit is again made aware because of your talk, and I feel everyone here who have listened to you would like to put some questions, and to be a person who is going to definitely die, starting from myself, the dignified way of dying is, I think, the first priority, the rightful way a person deserves. So, thank you. The real picture that you put forward is everyone is, grasping, thinking imagining things of how it's going to be at the end of my life. And to be very aware of it, to be consciously managing it is again individuals' dexterity that we have to see. Thank you so much.
Just to add, I'll just take a line. See, we all are born in this world. We celebrate it. And when we die, it is our palliative care society's duty that when a patient goes, that also should be celebrated in a dignified way. Yes, sir.
In the interest of time, one or two questions from the audience, please.
It is not exactly a question. Whatever we know about the end of the life care is more or less theoretical to me as far as minorities is concerned in India. Because I don't see any of the hospitals being practiced this one, because it's not only the medical team or medical personnel who are in it. We have lots of other people coming in out there. So how do you envision in India, in the coming how many years, we might have a very good team of this end of the life care? How we are going to practice this in the hospital?
You're absolutely right that we really are talking about theoretical aspect, but coming into ground reality, how do people die? As I told you in my picture, that ICU picture, we all land up there, and we basically it should start right from the grassroots level, because when a patient, we know that it is futile and we know that there is not much outcome. But due to peer pressure, due to pressure from your neighbors, due to pressure from your friends that take your relative to the hospital, what are you doing here? So we need to change this as well. So it is not just at the ground root level, it has to be started right from the policy makers that palliative care should be started and integrated in the institutions, in the tertiary level, in the district level, as well as in the primary health care and wellness centers. Once this is integrated properly, and once palliative care reaches in the ground state, and once we know that these patients have someone just nearby their house, nearby I mean in 1 or in 5 kilometer radius, someone is there to support, yes, a dignified death will be there, but yes, it may take some time. I can't say how long, but you'll be very happy to know that Dr. Suresh sir, he has a good vision in his mind, and with his work, we'll be seeing this very soon.
Very soon.
Yes.
Your question, sir, just to add my thoughts on that, we can have a dignified death for our people if we start talking about it. So if all the people sitting here today goes and talks about death with someone else, I think we are starting with a good dignified death for our people. Will we do it? All of you do it? Will all of you go and talk about death today? It's a difficult job. It is a difficult job. But if we start talking about it, I'm sure death is going to be dignified for our people. I'm sure. So please go and do that. Thank you.
Yes, I said I have conducted that the people are not that afraid to talk about death. They are not that afraid. Rather, the doctors are afraid.
Yes, this is also a situation. Yes, you're absolutely correct.
Dr. Puneet, I think your deliberation has enlightened me a lot, but I just like to have one clarification. Suppose one of my relatives, see, he is about 94, 95, he won't come back to life again, but his sons, that relatives like him to stay longer. I thought that, you see, we are torturing him, putting IV line difficult many times, lot of pain, then bed sore, etc. Is there anything that we could counsel the family that he's not coming back? The idea is let doctors do service to their parents as long as possible. But in fact, he has been torture, though I don't like it to be in my lab to be putting IV line, etc. Then nasogastric tube. Unnecessarily, if I am supposed to die, that is my wish. But for that family, could we health caregivers or palliative caregivers counsel the family so that he could die peacefully without this all these unnecessary torments?
Yes. Sir, this is a very common scenario, and this common scenario can only be addressed if we start integrating palliative care from the beginning. Once palliative care is started from the beginning, we can make a rapport, relationship building with the caregivers. We can teach them, we can empower them. That's what I told you initially, that palliative emergencies won't remain emergencies if the goals of care are properly defined. So once this is properly defined at the earlier stage, so the caregivers will know that yes, there is not much to do. If it is futile, not much to do in the sense that yes, the disease, we can't manage the disease, but the symptoms associated with the disease, we will be there to manage you as possible, as much as possible. So this has to be conveyed to them. Apart from this, it is not just telling, it is to empower the caregivers and to teach them what all they can do. If they can manage the bedsore at home, please teach them the various techniques how to take care of the bedsore. And there are feeding issues, yes, please ask them. There are many times that patient comes that he's not taking anything, he's not taking end-stage disease, emaciated. Then you'll have to explain them that there is not much role of these TPM for their metaparenteral nutrition. Once we explain them properly, they will understand. Yes, some patients are very difficult. Some, despite listening, they tell, no sir, please, I want something. But we should respect that also. And for those subset, yes, we can go to a certain limit. But to most of them, it is now our duty to start palliative care a bit earlier than we usually do.
Yeah, Suresh. I know that it's a bit late, but just one comment. What Puneet suggested about integrating palliative care at various levels is important, but that alone will not be sufficient, because the roots of, or the barriers to good death, the roots are much deeper. Unless, for example, this is an important event in each one of us life, or probably the most important last event. So we plan for most of the other events, but usually we never think about our own death, and we never discuss it. And I've been running what we call death cafes. Some of you have been in it for so many years. Small groups of people sitting together and reflecting on their own death, their own worries. And something that I interestingly observed is that most difficult group is doctors. Doctors, when you ask them to talk about death, they always talk about that patient's death, not their death. So we need to discuss this, because this is an important thing. We need to, at least we need to start thinking, how am I going to die? How I want to die? Which are the things that I want to avoid? So that sort of discussion, it cannot happen at the deathbed. Nobody will ask you, when you are about to die, nobody will ask you, how do you want to die? Because that will be a little bit cruel. But it would be good to generate, so that sort of awareness and death literacy is very important, along with facilities that you mentioned. Thank you.
Thank you, sir, for your...
Dr. Puneet, Dr. Sandeep here. In our part of the world, we have seen patients and their, not really patients, their attendants and their families getting violent. It is a real problem for us, especially for me in the emergency sector. So in your experience, this may be purely subjective, but in your experience, suppose a new patient comes to you. Patient is a prime candidate for palliative care. But in your experience, how much does counseling work? How much does initiating palliative care at the onset of, suppose at their time of admission, how much does it work, or does it work at all? Because in our part of the world, we have headlines making news that this happened, that happened, untoward incidents happened. So do we have any data on that, at least in the Indian setup? Or also, just lastly, my real question is, how long does it take for you to sort of make a rapport with the patient or with the patient's family? That's about it. That's just something I wanted to know.
See, whenever we get a patient, the first meeting is very important, and the first meeting can take 30 minutes to 1 hour, and in this we need to identify what the patient wants, what the caregivers want, and based on that we need to approach. Now coming to your question, suppose a violent patient comes. First of all, we need to know what is the reason behind it, and then we can address. There are many a times collusion is there. So collusion needs again special communication. We need to talk to the family, talk to the relatives, because there's some term as California syndrome. You explain the patient, you explain the caregiver who's present at that time, they will understand everything. But next day you see that someone has flown from abroad, he comes to you, he says, no, I have heard that, no, so please be aggressive, do everything. So there are times that continued communication is important, and it is not just one time process, it has to be repeated multiple times.
Excuse me, just a last question. I'm Dr. Bhavna. I work as a medical officer for the Central Agricultural University, and I had been working as a resident doctor in Shija Hospital for almost over a period of 10 years. And you've got, my question to you is, I have also been dealing with terminally ill patients. In fact, it was a very high profile family that I was attending to. And it was, the question that I want to ask you, we know that the life is going to end. But what about euthanasia? Like, we're just literally gaping and gasping. The patient was gasping right in front of us. So at that time, what do? Should we let the patient go? Because euthanasia is also one factor, just like it's not much talked about. I think as a palliative, as a caregiver, we should think about that too. Is it right from our part just to stand there and see, okay, let her go, and all medicines, dopamine on the side, everything we are pumping on the side, dopamine, but we know that's just not going to help. And the patient party, the whole family members are around. So this part, could you just throw some of your experience?
Ma'am, first of all, euthanasia means giving some medication which is intended for death, right? So as palliative physician, we don't use this word, and we are not encouraging this. But yes, when these type of patients come to you, your counseling will be very important. You will have to tell them that we will try to make you as comfortable as possible with these medications. But suppose with these medications still your symptoms are distressing, and he's very much distressed, so we can start you on something called palliative sedation or terminal sedation. The means here will be to provide comfort rather than death. We will have to explain them that we'll be putting you on to a level that you are comfortable. Not only you, once he is comfortable, your caregivers are also comfortable. So that you can't term it as euthanasia. This you will be terming as palliative sedation for the comfort of the patient rather than euthanasia.
Just allow me, because this has become a very interesting topic, and I just wanted to put my input regarding Shyam Kumar's question. If the patient party, they want to continue the treatment knowing fully well that nothing is going to happen. Shyam Kumar, what we are practicing, what I have practically done, is that the basic issue is that they have the feeling that the society, the others may blame them for not doing the best, and they will feel guilty about it. So if we convince them that you have done everything that is possible, this is the best you have done, there is nothing better than you, all of you, all the family members, all the steps you have taken is the maximum you have done. There is nothing, only now is to give comfort to the patient. I think they accept it very nicely, and that is exactly what we have done in very many of the patients who have died at home, and we have given end-of-life care at home. Just by giving sedation so that the patient just sleeps without any secretions, we give them medicines to decrease the secretions, and it has taken, sometimes it has taken up to 3 or 4 days before death. But until then, the patient and patient family are relieved and they are happy. And some of them have appreciated that and they have contributed to our society because of the smooth end of life that they have got. So once we remove their guilt from them, the feeling of guilt that we have not done enough for our family members, you convince them that you have done whatever you have done is the maximum that is possible, then it is easy to accept for them to let the patient go rather than try to take them to a higher center or do anything else. Thank you, sir.
That's absolutely correct.
One quick point. I think most of the questions out here to me looks like that we are missing the point. When we talk about the end of the life care, it's not about a single point in time. It's about a duration. So it's not only one contact that we are going to have with the patient or party. It's a whole length there. The whole length is a process. You have to go through that one. It's not at that point of time. Yes, and regarding this one is about the bereavement. Let me tell you, medical students are not taught about bereavement. The Kruger-Rose 5 stages of bereavement. That's the second stage. Anger, blame. This is quite natural for the patients to do it, patient party to do it. So as a doctor, we have to understand that one. Of course, communication is also very important. And by the way, active euthanasia is not legal in India. Yes. We don't give things passive, withholding or withdrawing. This is what we do. Thank you.
Thank you. Very nice, many interesting questions. And to wind up, last very short question, with this background of COVID-19 pandemic, many of our patients were strictly isolated and completely not allowed to be with the party. So in that respect, how do you involve the patient party in the care? Very short, very brief.
Yes, sir. So I was involved in my hospital during COVID times, and we had all of us have WhatsApp, right? We always involve the patient with their families and also with us using WhatsApp video calls. So I guess telemedicine, it's very important, not only in pandemics, but yes, it'll have a role in home care when we take care of our patients at home.
Thank you for a wonderful presentation, and it is like eye-opening for many of the youth like us for discussing about the date. We never discuss about the date because we fear death mostly. So, but we are open up this date. But the one thing I want to more elaboration is that when we discuss about the date here, we discuss either in the hospital or at home. But there are some cases where people die at the road, for example, accident, and when in that case, avoiding say respect of the dead body. So what is your opinion? Because many people, I have seen many cases like they pull the dead body to the truck and it is in that just like an animal who's dying in somewhere. So what's your point?
Yes, I don't have really much expertise on this, but yes, these patients also require a good dignified end, and the policymakers should come to they'll play the major role here. They should come to a point that they should provide, they should frame some rules, or they should have some SOPs where the disposition of these dead bodies can be taken with respect.
Say those working our forces, they need to be trained,
yes,
so that
trained
much care should be given, because I have seen, and we have seen also that when someone died road accident, they used to put up in the truck in such a way that some dead animals are lying there and they just throw away and when people see it, it's not we don't feel satisfied. Thank you for that.
Thank you so much.
For a very vivid and very nice explanation and a very rightly answered questions. Yeah, so we now next move on to the next session.
Next program is
for this session, we'll move on to the next presenter. We would like to invite two caregivers, Aman Jain and Kangabam Reena Devi, to share their experience, and the topic is caregiver burnout in palliative care.
We are coming to the last session. We have two caregivers, Mr. Amar Jain and Kangabam Reena Devi. Will share your experience with the audience, and we'll start from Mr. Amar Jain. Who is the patient you have? Who is the patient exactly to you as a relative you are taking care of?
First of all, very good afternoon, ma'am. My grandfather is the patient which we are talking about, and he was suffering from terminal illness. As we all know, we are talking about palliative care here, and we got to know during his last stage that he is into that, because earlier to that he was very fine. We didn't know something like this is happening to him, because he was walking around, he was doing his regular stuff, and he was a very exercising every day, and he was very jolly and healthy person. So on his last stage, like now he's not with us, on his last stages, like almost a year back, we got to know that he has a tumor in his kidney, and we were not very sure what it is until we got to know that while passing his urine, he's getting some blood clots. So we got it checked from the doctors, and then we got to know that he has got a tumor in his kidney, and because of which he's facing such issues. Then his kidney was removed. After that also, for 2-3 days he was fine. Like the doctors told us, after the kidney is removed, they were not sure what will happen, like whether it will be completely gone or not. But after 3 days he started he was not able to feel his lower body. So the tumor, it attacked his spinal cord, it seems. So he was not able to feel his lower body, and he was completely bedridden. He was in Bangalore that time. Like we took him to Bangalore for the treatment. So since we already had my own uncle, suffering from same terminal illness, before, we knew what kind of pain they go through and what kind of care they'll need. And we also suggested our family, asked our family doctor as well as other doctors who are in touch with us. So they guided us saying, you cannot go for another operation, because he was already at his age of 80. So they guided us, don't go for another operation for the spinal thing. It's better if you can, go for palliative care, what is the home care. We also decided for that, and we didn't go for surgery. So this is the background, and we brought him again to Imphal, and where all of us were here, his wife, my grandmother, and all of his, my dad, uncle, and all of us were here to take care of him. We decided not to take him to the hospital because doctors told us that he wouldn't have a very long life, like maybe for 3-4 months. That was a year ago, and we lost him recently, 1 month back. And he survived for 1 year, I would say, because we never told him what actually his disease is. So he was in the hope that as soon as my health improves, I'll be able to go for spinal surgery and everything will be normal. He was not aware he is a terminal ill patient, and that's how he was very hopeful of. And he was never like that he will tell us what the pain and all what he was facing. He used to tell us, but he was not aware of why he is facing that. So he was always hopeful. That's the background which I wanted to say. If there is anything else, I can always put a light on it.
What point of time did you let him know, yourself please, at what point of time did you let him know that he is terminally ill and is not?
He did not know about it until he was, very in an unconscious stage. Because until that time, all of us, including his wife, all of us were aware about his situation. It's not that we hid it from his wife also. It was all of us were aware about the situation. Only he was not told about it, because we know that since his own son he had lost because of the same illness, so he knew what the pain is, and he would have lost his hope if we would have told him what the problem is. So we decided not to tell him, and that is what we kept till the end.
Suggestions that you would tell to the public, what more could be done, or any
the problems which Dr. Puneet had rightly told here, like the symptoms that he told, all of it is very relevant, and we could see from our own, I'm a first-hand experience person for all of that, because we had to be at home whenever he's facing any problem. So all of our lives were up and down. We didn't know when to go out, when to be in, because anyone could call us again, come home, he's facing this problem. So, and my grandmother and all, they're not very much aware about things, what to do. They get panicked. So we are the ones who will be consoling them and giving them the hope that everything is fine. Only few medications and certain things are required to get him to normal. So we were given this, we used to consult Dr. Nandan also, he's here, and we used to consult him, and he was also very kind, and he supported us, and he told us, see, at this stage life is very, it'll be very painful for him, and since it's painful for him, it'll be painful for you guys also. Because for our own loved ones, we cannot see the pain. We are all born and brought up like that. Like we cannot, though we know the condition, we still think that he'll get normal. That is what we hope till the end, that everything will be fine, everything will go away. That is what we think and what we wish for. But since the illness, we don't have a very concrete solution to the terminal ill patients, like the medical facilities and all are, though it's very advanced, but for terminal ill patients we cannot say that things are, it can be brought to normal again. We all were aware about it, and that's how we continued everything. We took care of him how much ever we could, and we were there for him, for listening to his thoughts. And since his lower body was not responding, he couldn't even get up and move. He was all bedridden. He got bed sores. We took home care for bed sores also, and we were very fortunate enough to have doctors around us and to consult them. And the technology is also very, we could do video call to experts to know what to do, and that's how we took care of him for a year. When the doctors told he would only last for 2-3 months, he was there with us for a year. So we did whatever we could do from our end, and we didn't lose our hope, and we didn't let him lose his hope, which is more important than our own this thing.
I have a question then. Is like any of it like care is taken care at home or in the hospital for your case?
In our case, everything was taken care at home. We didn't take him to the hospital because, as we were earlier told, that only 2-3 months he has, and since we already had such a patient in our family, we knew that such kind of illness has a very shorter span of life. So we wanted him to be with us, and so that we can share whatever we have to tell him. In hospital, we all understand that no one could go and meet him every day. In our own home, though, every day we used to visit him twice or thrice, or whenever possible we'll go and sit with him. Everything else was secondary, only the priority was him.
So I have one more question then. So you have seen your like a grandparent, right? So it's passing away with your eyes. And what you learn from there? What is your learning? What is your understanding of life from there?
As I told earlier that until we were given the information about the disease he was having, he was very jolly, healthy, and moving. So as soon as we heard about it, everything was we didn't know what to do, because such a person whom and a grandparent is someone everyone loves, because he's he's been with us for so long and always jolly and always happy. So for this we understand that life is very, and with COVID also we got to know that we cannot expect anything from life. Death is certain and it can come at any age. It's not that I'll be only it will come when I'm elderly or something. It can come at any age, and we can't even say that why this to me. He can't even say why this illness has come to me. I didn't do anything wrong to any person. Things are uncertain, and we should awareness and information is something which is which should be spread from the doctors and from others also. As a volunteer also, I'm ready to do anything whatever is possible, because awareness and information is pending. Even from the childhood stage we should teach them, see, death is certain and it's very normal. We should be able to tell them how care should be given, how things should be taken care, because palliative care is something which we got to know very recently. Maybe it's there from decades is what is told to me, but we didn't know about it even after, I'm a tax professional, so we are aware of things much more because we keep on talking to people. But still I didn't know about palliative care, because I think so much lack of awareness is there in the society that there is something called as palliative care, with which the terminally ill patient, they can they can have a dignified death. That is what was told. So we were not aware, being in such a society where we talk to people also. So what about other people who are not very much closer to the society? And I think awareness and information is very much required at this stage for everyone to know what is palliative care is, what kind of diseases require palliative care and how it's done, and how financially draining it is, or whether it can be given at home or only at hospitals. we are not aware about it because we are general public and we don't know how things are, and we didn't even know whether it can be given at home also. We gave palliative care from our own family only, like that was the palliative care we could give, because we didn't know that there is certain terminology called palliative care which is specifically designed for terminally ill patients. We didn't know about it until we spoke to him and we got to know about it.
Thank you, Aman Jain, for your very detailed explanation about your experience. And the best thing that you have done is to have given a very peaceful and dignified death for your grandfather. If I were in your place also, I would have done the same. And we hope that we will spread more information as you have suggested through our activities. So we next move on to our next caregiver, Honorable Rina Devi. So
thank you, sir.
You kindly share your experience with us.
Thank you, sir. First of all, very good afternoon to one and all present today. I wholeheartedly thank you, Palliative Care Society, myself, Rina. My father, a well-known teacher, is suffering from paralysis, whole body, for the past 14 years. Before palliative care was introduced into our family, our family has gone turned upside down. He is the only earning member in our family. After that, every day we live in chaos. We live in streets. Then one of my father's student introduced Palliative Care Society to our family, and he mentioned about their care, their support. And after that, palliative care people came to our home, and they mentioned and they taught about their services. Then after that only my father came to know about their support and care. Then being after their support and care, he came a little bit calm, and with their support only till today he is still surviving or still happy with the care that the palliative care is given to our family. With this, I'd like to thank wholeheartedly again with all my heart from my family side.
You are saying that your father is for 14 years as paralyzed?
Yes, whole body, and now he is in bedridden.
So how many family members you have?
We are only 4 family.
4 family, including your father, like
Sorry,
another
sir?
3, including your father is a 4 family member.
Yes,
Okay.
although he has brothers and sisters, but in today's work, they also has to go for work, and also not every day will come and check our family. We have many relatives, we have many neighbors and all, but from the day he has been paralyzed and been hospitalized, they usually come to our home, they support us, but after that, slowly and slowly, people misses us and all. Through now, though they only ask how is your father's health and all. So just mental support.
I feel the same. I'm also feel like my father is more than like 4 years in bedridden.
Yes.
So I feel like kind of the burnout from the family members. Even my mother, she never sleep. For the last 3 years, she always take care for my father. But when someone is taking care for another person, so the caregiver is the burnout for the caregiver. We should all be taking care. I believe that it has happened to your same family also, because of the one who is we need to take care for someone, but we should also think about the one who is taking care, the caregivers. So I believe you will feel the same, that kind of burnout in your family.
Yes, absolutely.
Can you please tell a little bit about that part also? This is the part we want to discuss.
Okay, since we have 4 members in our family, my mother is the one who support 100%, 24/7, day and night, taking care of my father. My brother is working as an IT technician now. Before that, we together work from the relatives. We got some assistance and all. Then after that, I also got some private jobs and all. Through that only we got supported our family. and we got some assistance from my mother-in-law's place. So before this palliative care, it was very hard for my family, because every day, as I already told, we live in chaos, we live in streets. Then just after the introduction of this palliative care with my father's student, they along with our respected Sir Jugindro sir with his assistant staff came to our home. They not only give support mentally, physically and medically, they give my father those all kind of the mental support and all. Till today, if this palliative care society, if they came to our home and if they give a date to my father that they will come and visit next week on 23rd, like Wednesday and all, he will tell me to mark that date on the calendar. And if suppose if there's some other work and all, if they could not come on that same date and day, he will get more stress. Like he will say that what happened today, if what might be thinking, am I going to die or something like that. My father usually think like that. At that time I usually give them, they also have certain other patient to visit other houses. If not today, they will come tomorrow, or they will come day after tomorrow. In that way, we usually supported him. And palliative care also, they never fail to visit our home, even if the date is misses and all. So I again wholeheartedly thank from my family this care society to give us more support, to my family members, to my fathers, and this I can say.
One more question, maybe the last one. From your experience that you shared with us, what contributions from your side, from your end, would you do to the Palliative Care Society? If at all, how many families will you make aware of the Palliative Society that exists now at Imphal? Would you put some efforts on from your own, voluntarily?
Okay, ma'am. Since I am a part of this palliative care society with my family, I have the experience of it. We have certain community localities, and like I said, we have, so we can give our locality and things about this palliative care society, what they do to the terminally ill patient and all. And I also request to this society to give certain talk on all the locality and the locai and all about this society, because in many of the Manipur and Imphal states we have certain clubs also, madam. So we can tell them to thoroughly give them about this palliative care society talks and all. Even I can give to my lekai and the club about these talks. And I also request to all the members present today, respected doctors, nurses, students, myself and staff, to please take part in the palliative care, to be a member of this, because I myself has already gone through all this sort of this illness and terminal illness which my father had done. The only thing that you will know is that when your family is sick, you will be the one who will support your family. But please give a little bit of your heart as for the sake of humanity and all. Then only you will come to know that palliative care is also a good part of it. Let us share a bit of our humanity, humanity to the society also. Thank you.
Question from Sister Silky. Or comment or question.
Very good afternoon to all the respectees of today's program. I'm not an expert, but I just had a thought and I just wanted to share in this August gathering. We have been talking about palliative care and how it is related to death and dying. What my thought is, palliative care is bringing a balance. Maybe I'm not right, but It's just a thought that came to me. It is bringing a balance in our society. Like we are giving care and dignified death to the dying, at the same time we are building our future. Like we youngsters, everybody present here, there are a lot of young bloods. So when we go with this process and when we are involved, we see the patients. Like for example, a patient who is having oral cancer that is due to ingestion of tobacco products, or a person who is lying in the bed, or who will be lying in the bed due to a road accident, due to some road accident cases. So when we are involved, when we see it, like when we go to that place and when we feel it, when we hear it, when we see it with our own eyes, then there is no need for the parents to say to their daughters or to their sons that you don't take this tobacco or you don't drive fast in the road, because we will, or the young bloods will realize with themselves that if we do this, then such things can happen. So I would like to share that palliative care, if it is not just about giving care to the dead and dying, but it will bring a balance in the society and in the future. And if we are all involved, then in near future there may be less cases of accident and any other disease that we would like to avoid. Thank you.
Thank you. I just want to know something from the two champions of palliative care. I also had my share, of course. I had my mother with dementia and I was taking care of for the last 10, 12 years. So I had my moments of frustrations and anguish. At the same time, I had my moments of joy and happiness with my mother, even if she is dementic. So in that way, I would like to know from you two, the champions, just share, if you can, if it is not that personal, some of the happy moments that you share and some of the worst, or rather the very frustration that you have shared and how you cope with that one. Thank you.
There were a lot of moments that will come to us because he was there with us for a span of a year. So we used to make sure that whatever he loves, we provide him that. He was a very sporty person, so he used to watch cricket. Every match of cricket he'll watch all the matches of kabaddi, he'll watch FIFA World Cup matches, and he used to make sure that at the time of match someone or we all are with him to enjoy the match, because we all know that sitting alone and watching the match is no fun. Only with our family and friends we can enjoy the moments of. So we used to make sure whatever it is, wherever we are, at least all of us will sit with him and watch the match, discuss about it, so that he forgets about the pain what he's going through. And the kind of pain that he was going through, he was very he very rarely he used to tell us that okay, I'm having this pain, because he understands that if he tells something like that, all family members will be worried. So we also used to make sure that whatever, any occasion, any birthdays, anniversaries or any other, we won't celebrate it anywhere else but with him. All the cake cutting ceremonies, photographies, everything will be done with him only, so that he knows that okay, my family is around and they are all there with us, and at least we'll try to make sure that he forgets about the pain that is going through by whatever way possible. And the second question what he asked was, there were moments of sorrow and when he'll be very angry and he'll be frustrated, because at that time when if we even think that my lower body is not working and I have to lie in bed for a year, we couldn't even imagine such a situation which was going through, because he couldn't do anything with on his own self. Even feeding, he was dependent on someone. So such kind of a situation, there were times when he was frustrated, when he thought why I am going through this, what I have done, and we used to make sure.
I'm talking about from the perspective of yours, not from the your frustration.
Our frustration,
Yes,
okay.
Yes, your moments of joy, your moments of frustration, not the patient's perspective.
Yeah. Our moments of frustration were like, I can tell more about my grandmother because she was very close and she was the one who was dealing with the situation 24/7. She used to like, I don't think even she used to sleep 3 to 4 hours a day. That was because he couldn't move himself, but he would want someone to move him even at the midnight. So my grandmother, she used to wake up, she used to turn him around. She was very frustrated at times, because at times we all think, why I am in a situation like this, why my husband or my grandfather in such a situation. And she was frustrated a lot of times. She used to tell us that, see, certain things are not in my hand, we all have to tell him that what he's. So we didn't know what to do at such a point of time. We used to call doctors and other relatives and console my grandmother, because she was the one who was very close and 24/7 taking care of him. Those frustrations are very hard for even other members of the family to handle, because we know what she's going through, what we are going through, what the whole family is going through. So at that time, the role of doctors, relatives and all comes, and they give us the sense of understanding that, okay, things will go fine and one day everything will be okay.
Sir, your answer to your first question about frustration. Yes, there are frustration. There's a time that when we could not meet his demand, both of the side there are frustration. But at that time, I am the first one who cools down. I usually ask him to that we will give you what you want, we will try to make you this and this. And as a joke also, I usually tell my father that if you keep on demanding this and that, if you are stressed or if you are this, I will call Sarjugendro itself. That is one thing. Then second answer is that I have two daughters. And when he is very much that thing, I usually bring my two daughters to near him, and when they laugh and when they jokes, he usually his stress is out. So there's a saying that when there are children and they're in your home, they are always laughter. Thank you.
Thank you for sharing your wonderful experience in the happy moments and all the sad moments. Thank you once again. And sir, I took this occasion and this function as a privilege to announce that Medellin is going to introduce wheelchair accessible taxi in next 3 months, because it is very hard to my father. My father loved to travel a lot, but he asked me to buy a car. Whenever I pick up the phone, he asked me, have you buy my car? So I said yes, but my car could not fit my father. So that's why I thought that I should design a vehicle where wheelchair can be entered and people can, like my father, can roam and see the places. And I want to give this vehicle, when this is functional, particular day, one day, for the palliative care patient which is enrolled in the Palliative Care Society in Pallicon. Thank you.
And sir, one more thing, is there a ways that all these patients like sir's, his father, I guess, so if they can contact through WhatsApp video call in, and if they had shared their feelings to among his patient, if they can talk, then there can be a good, I think, support to each other. Is there possibilities of such things?
Yeah, that will be, we can note this point. Thank you. Thank you.
Thank you, chairpersons and the esteemed speakers. That was a very interactive session. Thank you for sharing your experiences in the difficulties faced during end-of-life care. Now, I would like to request the chairpersons to kindly felicitate Dr. Puneet Rathore for highlighting the various aspects to be considered at the end of life care. Sir, please, the chairpersons, please come on this.
You can be there, you can be there. You stay there. You stay there only. Chairpersons come and Dr. Puneet.
I would like to request the chairpersons to kindly felicitate Aman Jain. I would request them to felicitate K. Reena Devi.
Thank you. And now I would request Dr. Jugendra Surakaidam to felicitate all the respected chairpersons on the dais.
Ambulance with the wheelchair. One day, sir, it's a taxi. People fear ambulance, so that's why we call this one day taxi. Okay, taxi. One day in a week.
Let's fight. I want to express humble thanks to all the Palliative Care Society in Pallicon. I was working as a volunteer in Palliative Care Society
when I was a medical student. I was joining for I think it was the first day of the visit. I joined as a student volunteer, and I'm so happy to sit as a panelist here again in the stage. Thank you so much, sir, all the opportunity and all the support. Thank you, sir.
Thank you, sir. Thank you, all the chairpersons. Before we move on to valedictory function, we would like to announce that rupees 1,000, 2,000 and 3,000 was given respectively to third, second and first prize winners for the award paper presentation to encourage more research in palliative care. Now we would like to move on for valedictory function. For this function, I would like to request Dr. KSH Manglem Singh, Organizing Chairman, Pallicon 2023, Dr. N. Suboda, Secretary, Palliative Care Society, Imphal, Dr. Brogin Singh Akoijam, Chairman, Reception Committee, Dr. Suresh Kumar, Director, Institute of Palliative Medicine, Kerala, and Dr. Jugendra Surakaibam, Vice President, Palliative Care Society, Imphal, to please join us on the dais, and Dr. Nandan Chaudhary, Organizing Secretary, Pallicon, to join us for the valedictory function. I would like to request President of Pallicon 2023 to please conduct the valedictory function.
Good afternoon, everybody. So, after a hectic sessions for 3 days, we had pre-conference workshop at Nambol Peace Museum on 2nd. We are conducting conference here on 3rd and 4th at Silver Jubilee Hall. So, this is time for farewell to all. So, all the delegates, faculties, all the members, committee members, subcommittee members, each and everybody participated in a big way. Actually, this conference finally came out to be a very big and successful one. This we did not anticipate at the beginning. All because of your contributions. In matters of finance, spending time with us, and all those contributions academically also. We gain a lot out of this conference. So we could contact with the experts in the field of palliative care from India and abroad. That was quite exciting. So it goes on well. So I would request organizing secretary, Dr. Nandan Chaudhary. He is the main architect of all these developments here. I would like to hear from him.
Very good afternoon to everyone. First of all, I would like to thank Subhadra sir, Logan sir, Jitendra sir, Maglim sir, that they decided that this organizing secretary opportunity should be given to me. I was not expecting to be organizing secretary, but I was given this job. And so I was really afraid that how will I do this? This is the first time I'm doing this, and I'm very much junior to everyone, and I have no experience. But I would like to mention that we have a medical social worker, Roser, who told me that, sir, it will be done, don't worry. So I was very happy that time that, okay, it will be done. We have done it 3 times, so it will be done, don't worry. And then we started, it was very less time, I think, I remember only we had around 2 months. And with the help of all the like organizing committee, like Sir Gautam sir, he helped a lot, all the IT people of CISA, Prem Kumar, Ramson, and all other members, I can't say the name, but Sanatumbi, she also helped a lot, and all the students of CISA and RIMS, they all contributed, I think. I might have missed someone, but they all contributed a lot to help me to organize this conference. But I was not expecting this much of people, and to surprise, there are a lot of people here. Till the end, even Sir Julinder told me that at the end you will see only few people only. But to my surprise, there are a lot of people here right now. So I feel very happy that The motive of this conference was to bring awareness. I think people coming here, at least you should spread this message that palliative care is required for everyone, at least to 5 people. So that if we have gathered here 200 people, at least there will be multiple, the message will go into multiple people. And I'd like to thank everyone, the delegates, all the speakers, all the chairpersons who came and contributed to this conference. Thank you all.
I will invite Dr. Suresh Kumar, Director, Institute of Palliative Medicine, Kerala. And again, he is the Chairman of the Pallicon Scientific Committee. Please give a message to the gathering.
Yes, happy to be here at the finishing point of the fourth Pallicon. And looking back, just been both like quality-wise and also content-wise, it has been a steady improvement from Pallicon 1 to the fourth one. And also this one, this particular event saw the emergence of a new organizing secretary from the younger generation, Nandan. And the content-wise, academically, the whole exercise has been getting better and better. And also by level of participation, different levels of participation. So, and this is, I think this is mainly because in the background, the palliative care activities in the state has been improving and getting better. So that is being reflected, and it's connected to each other. What we discuss here is related to or relevant to palliative care in Manipur, and what the problems and issues of palliative care or the developments of palliative care is brought to this forum for a wider audience. So I think we need to continue this activity, and this time it has attracted quite a few people from abroad also. They are presenting online. Good that we are developing faster, and then let's hope that this sort of progress will continue, and looking forward to the next Pallicon. Thank you.
Thank you, Dr. Suresh Kumar. Now I invite Dr. A.K. Praveen, Professor and Head, Community Medicine Department, RIMS, the Dean Academy. So he is also a very big contributor in the success of this conference. In fact, we did this conference here in Jubilee Hall because of his inspiration and suggestion, and he contributed in many ways in matters of providing staffs and arranging everything so that no shortage, no deficit, shortcomings there. So I would invite Dr. Brogan to say a few things from your side.
Thank you. This conference, probably this is the first one that I'm attending in terms of the Pallicon. Though I registered last time, I think I wasn't able to attain. And this time I suggested that I would like to hold it here along with you. And the PSI, the Palliative Care Society of Imphal, they readily agreed, and for that I thank you, the President and the Secretary. Though we had hitches, as usual, nothing is perfect in this world. This conference turns out to be a grand success, I would say that. Probably most of the delegates are still here because I did one conference on the adolescent health, and there also, till the end, delegates were there. And one of the tricks that I played was that I gave the certificates later on. And probably I think it works here also, a bit of it. I'm thinking on that one. Because they need the certificate for many other reasons, and that's a good thing. And it is also the right thing to do that way. And thank you again, all the delegates, for being here till the end. Now coming to the palliative care, something that we need to know about is
we have the science part of it, and we have all the scientific people, all the experts coming in, talking to you. At the same time, we also have a societal component in it, and for that again, we have people who really care for that one. We have NGOs, we have individuals contributing to the palliative care cause, and we also have academicians, and we have the other psychosocial support system also. I think all these people come together in this palliative care society. What I wish now is science part is not out, it's very much developed. We know what to do, what not to do, everything is done. But in practice, in India, we are in an infant stage. And I think through this conference again, we learn a lot, the science part of it, as well as the psychosocial part of it. And the expert also, I think, they must be learning a lot through this conference. It's not that everyone knows everything. Life is always a stage where you learn till the end. So I think this conference gives that platform, that opportunity for us to learn each other. And through this learning, I'm sure the experts, the science part experts, as well as the social part of it, all the people will further their work in order to improve the palliative care in India. Let it be a small step in the hierarchy to reach the height of the palliative care in the country. Thank you.
Dr. Jugindra, Vice President of UCS. Actually, this Palliative Care Society of Imphal is the brainchild of Dr. And he has got a dream. He expected many things from all of us. So he's a big dreamer, and he did it to some extent. He wants to elaborate it. He wants to expand it. Now he will be very happy to the success of this conference, and I would like to get some comments from him. Thank you, Dr. Imphal.
Thank you, sir, for that opportunity. I congratulate Dr. Nandan Chaudhary for the conduct of this, arranging and conduct of this conference, and thank him also, and thank all the others who are involved. I will not name them all. Just my thoughts on the next Pallicon. If all of you agree, earlier we were doing it in 2 years' time, but my suggestion, and I would like the panelists, the people here also to decide whether we should have it every year so that we can do more activities and upgrade knowledge, and then also to spread knowledge amongst the people and public and the students. So shall we have it every year? If we have it every year from next conference onwards, I would suggest that we put the conference date for the next conference out, and then start registering during the conference. Like if we had registered today for the next conference, probably many would have registered. We can start doing that. That would be my suggestion. I would like that this conference now takes off into an annual affair, so that we are meeting more often, and we can spread the knowledge. I would like to have the opinion of Suresh particularly in this regard, and we'll follow his advice, and we'll move forward. Thank you everybody for being here and making this successful. Thank you. Suresh.
Subodha.
Ideally, it should be done annually, but then the sort of efforts behind it. So if we are after that, but definitely we'll continue that biannual one, but maybe a mini conference, something, an alternative would be regular once in 2 years, but a mini conference in between, because the only issue is because we know about the time and effort that all of you have been spending on it. My suggestion would be biannual, but something in between.
Now I invite Secretary of VCSI, Dr. Subodha. He also sweated more in arranging this conference. So I should take your comment. Please speak up.
Good afternoon, everybody. All good things come to an end. And personally, I think this conference, along with the workshop, has been a very good one, and I have thoroughly enjoyed it. And I hope it has been the same with you all. If you agree, you please put your hands together for the conference, for Pallicon. Thank you. Thank you. I should mention a few names. It is I feel in my duty if I don't do that. All the groundworks have been done, especially by 3 people, as has been mentioned also. Dr. Nandan, Mr. Roger, and Sister Sanatombi. There are many others also, but the main bulk have been done by them. And I think they really have been, and whatever was decided, no, they never said it will not be possible. With lot of positive energy, they say, oh, we can do it, we can do it. And actually, I was not thinking that it will be this good. And this conference, along with the Palliative Care Society Imphal, it was jointly organized by Community Medicine Department, RIMS, and National Health Mission Palliative Care Society, Palliative Care Program. So I must thank from my heart Sir Brogan, who has been so instrumental in organizing all these things, because it is conducted in RIMS, and he said everything will be done here. There will be no cost for the hall. So all his magnanimity and his team, they have done a wonderful work. And Dr. Premasandra and Dr. Tilakeswari, they have been helping us all the time, and particularly for this conference with a big financial contribution and all the works. So they need a big thank you from all of us. Then all the contributors, big and small, from so many individuals and societies. I cannot name all of them. And I want to just mention few names which I remember. Madam Bonnie, when we are a very poor society, we didn't have much fun, and the collection from the registration and all, it was not enough. So when we requested Madam to sponsor one dinner yesterday, she happily agreed, and yesterday's dinner was sponsored by Dr. Boni, the CEO, Caesar Hospital. So thank you. Dr. Suresh has been the force behind us, for all the organizations, for all the conferences, or all the Pallicons. She has always been there. He has always been there, and whatever requirement we pass regarding the scientific programs, and whoever people we want to get for the program, he will be there, and he is always helping us. In fact, many other organizations all over the country, they are angry with us, because we are always getting, Dr. Suresh always goes whenever we request, either by the society or by the government from Manipur, and he is too busy to come for them. So sometimes they are very angry with us that we are taking Suresh as our own. And I have to mention Dr. Jugindra, who is the one who started all this process in Manipur, and we were all together with him, and now he is pushing us from behind the quality of a true leader. He was leading then, he is pushing all of us from behind and to do all these works. And I have to mention one more name. I want to mention Madam Babita. She's a principal of she's Academy of Nursing, and she has done so much work for this conference, running around to get so many things for us, and organizing the cultural program with her students, free of course, without charging anything from us. And again, all the volunteers, all the members of the society, and all the students who had participated in the cultural program, and all of us who had come to attend and to make this conference a big success. All the caregivers, volunteers, students, I thank from my heart once again, and hopefully we'll make the coming conferences and the service of palliative care in this state a big success. Thank you all once again.
So, I think what the Secretary spoke out may be taken as for of thanks. Now, we conclude this valedictory program, and with the message, we depart just to meet again. Thank you. Thank you.
Thank you all dignitaries on the dais and for sharing your experiences and your words of wisdom, and for all contribution to Pallicon 2023.
Thank you all the delegates for taking out your precious time and joining us in 4th International Conference Pallicon. Before we wind up and move for lunch, I would like to end up on the note, end of life deserves as much beauty, care and respect as the beginning. Hope to meet you again in next Pallicon. Thank you.